All right. Good morning. Welcome back to the second day of our joint interim labor, health and social services meeting. We will go ahead and start with roll call.
Good morning. This is roll call for joint labor for May 15th, 2026. Senator Crum?
Present.
Senator Hutchings?
Here.
Senator Scott? Senator Steinmetz?
Excused.
Representative Plouston?
Here.
Representative Guggenmoss?
Here.
Representative Heft?
Here.
Representative McCann?
Here.
Representative Rodriguez-Williams?
Here.
Representative Thayer?
Here.
Representative Wassenberger?
Here.
Representative Yin?
Here.
Co-Chairman Ottman?
Here.
Chairman Brennan?
Here.
We have a quorum.
All right. Well, our first topic up today is healthcare provider shortage and accessibility of healthcare. And we'll go ahead and get started with that. Due to, I think, circumstances beyond their control, the department's going to be on line with us today for this part of the meeting. So welcome and go ahead and give us your presentation.
Thank you, Madam Chairman, members of the committee. Hopefully you can hear me okay.
Yep.
My name is Franz Fuchs, Deputy Director, Department of Health. Again, the director sends his regrets he can't make it. He apparently is in a very phlegm-hacky, noisy stage of his illness, and so it's probably best that I present this. We don't necessarily have any slides for you, but we just wanted to have a general discussion and certainly entertain any questions you might have about specifically how the Department of Health as a payer, and I think most importantly, its Medicaid and CHIP programs affect provider networks and access to care across the state. Generally speaking, as a payer, I think you should think of us as a relatively significant insurance company in the state for low-income and folks with disabilities. And then you all as the legislature are effectively the board of that company, and you decide essentially how much money you want to allocate and the rates we pay. Every time we do a rate increase, we come to you for a request. And similarly, anytime we need to cut money, cut rates in order to stay within budget, we also bring that to your appropriations committee and the full legislature in our budget. With that said, the rates we pay definitely affect access, right? That's the single most important lever we have. There are a couple other things we do to help providers enroll. We try to create as little hassle as possible for billing and submitting claims. We don't do a lot of prior authorization and other things to, again, create hassles. We pay fairly quickly. Those are things we can kind of do on the margin, but at the end of the day, the rates really matter. And so we do monitor provider participation in Medicaid pretty closely. And when we do see trends, when we do see providers tending to leave, then we will usually try to come with a rate increase to try to attract them or stabilize the pool of providers. I think the most recent example we have is home health providers on the state plan. So these are not waiver services for people with intellectual disabilities, but these are mostly kids, really high needs kids that are coming from children's hospitals or really high needs acute care settings and trying to come back home. Those are the kind of it's a relatively small group of folks and a relatively small provider pool, but we did see significant attrition in that and warnings from the providers that they weren't going to serve clients anymore. And so we did come with you in this last budget with a request for an increase in those rates, and we were certainly grateful that that was approved. So we do hope that that pool of providers stabilizes. Before that, it was with Medicaid dental. We did see a decrease in the number of dentists that were seeing Medicaid kids. And that was we requested a rate increase a few years ago and received that. So again, the dentist enrollment has stabilized since that time. So We do try to calibrate, when we do see provider decreases, we try to calibrate those rate requests. That said, the provider behavior does depend on a couple things. I think the biggest factor is going to be the market share that we have as a payer for that provider's book of business. It's very significant. This ranges significantly across the gamut, right? So really, like specialty providers, Medicaid probably makes a fraction of a percent of their book of business. For hospitals, probably 10%. On the other hand, we have nursing homes, which we pay for 65% of the bed days in a nursing home. So that nursing homes are much more dependent on Medicaid revenue than those other providers. And probably at the furthest end, we have our providers of service waiver services for folks with intellectual and developmental disabilities. I would guess that those providers are probably 90% plus Medicaid revenue. And so how providers respond to Medicaid rates and cuts really kind of depends on that book of business. Generally speaking, for the lower end, for folks where they really don't depend on Medicaid to make revenue, they will either just drop out, they won't participate, or they won't enroll, or we have to, in some cases, if we can't find somebody in state, maybe we have to negotiate a special rate with them to try to entice them to take a case by case basis. With hospitals, generally speaking, we are a relatively low percentage. But I think generally most hospitals see Medicare and Medicaid as kind of a package deal, and so they do take Medicaid. Most hospitals will take Medicaid patients even if they lose money on those patients. And there are other programs out there, these upper payment limit and supplemental payment programs that do try to bring the Medicaid revenue up to at least Medicare levels for those providers. And then when it comes to the very high dependent Medicaid providers like nursing homes and IDD waiver providers, there's a much higher risk there if Medicaid revenue isn't sufficient to cover costs, and they can't withdraw from the program because that's where the revenues comes from. So that's really where the risk of potential closures or service terminations really comes into play. And so we do try to look, when we're looking at different providers across the spectrum, we try to look at how dependent are they on Medicaid revenue to kind of assess the gravity of if they choose to participate in Medicaid or not. So with that, Madam Chairman, let me just stop there and see if there's any questions from the committee or requests for any research or anything you want us to pursue before your next meeting.
Any questions? Senator Scott?
Madam Chairman, you combine Medicaid with Medicare. What percent of the book of business in terms of actual volume of work, not reimbursements, but volume of work, is that for the various varieties of general hospital we have in the state, the critical access and the larger ones like Casper?
Madam Chairman, Senator Scott, I could hazard a guess, but I prefer, if it's possible, to get back with you in our response memo with some more precise information. I think we can sort of get that much more precisely from the hospital cost reports in a response back to you within a few weeks.
Okay, Madam Chairman, that's fine. And the reason for the question is that, and I don't quite understand, but I think the Medicare rates provide sort of an upper limit in what we can do in Medicaid, do they not? And we wind up being the regulators for how much the hospitals can earn. And I wonder if the two programs together, given the influence of CMS on both of them, aren't really the determinant of the financial health of those key institutions.
Madam Chairman, Senator Scott, I do think that when you combine Medicare and Medicaid, the volume certainly, as far as patient days, is probably one of the higher, probably upwards of 60%. 50, 60% of a hospital's volume total, because obviously the risk of hospitalization, particularly on the inpatient side, rises with age. That said, Medicaid itself would be much lower percentage of the volume. I think the interesting interplay there is we do cover a lot of Medicare eligibles who are low income. We call them dual eligibles, Medicare, Medicaid. And in that sense, we pay, for many of those members, we pay the cost sharing component. As you know, Medicare only covers around ballpark 85% of costs, right? And so a lot of folks buy Medigap programs or are in a Medicare Advantage plan. And for low income folks that are dual eligible, Medicaid serves as that Medigap program. That's a little more nuance there, but I think we can certainly try to get you some good estimates in our overall response memo as far as the volume and the overall revenue percents.
Madam Chairman. Am I right in thinking that the federal regulations are such that the hospitals aren't allowed to charge more to bring their patient revenues up to cost?
Madam Chairman, Senator Scott, in some ways that depends on the type of hospital. So absolutely for the prospective payment system hospitals, they are paid on a prospectively, meaning that it doesn't matter what it costs them to deliver that service. Medicare will only pay X dollars for an episode, right? So that episode might be, knee replacement or a sepsis episode or whatever. They're called diagnosis related groups, and they will pay a certain amount of money just based on national averages to that hospital. So in that sense, the hospital can charge whatever it wants, but it's only going to get that prospective amount, and that's all it can take. On the flip side, the critical access hospitals do in their cost base, they have a cost-based reimbursement structure, so it's not prospective. So as long as it's a Medicare allowable cost, generally speaking, they are reimbursed at 100 to 101% of that allowable cost. And that said, there's some caveats there. I'm sure you can hear from the hospitals that there's a lot of costs that hospitals incur that aren't reimbursable. A lot of physician-related expenses, for example, are not considered allowable costs for reimbursement, and so on net, that 101% may not be as good as it sounds, but it's certainly better from a reimbursement perspective than the prospective payment that the bigger hospitals receive. So I think to answer your question, yes, the hospitals generally can charge what they want, but at the end of the day, there's a methodology to determine what Medicare will actually end up paying.
Representative Clouston.
Thank you, Madam Chair. Thank you, Mr. Fuchs. Last year, we finally increased what we paid for EMS services. I think we went from 68% to close to 100%. We hadn't done an adjustment in like 14 years. I've been looking at the idea of if we had a payment policy for Medicaid, whether that was 90 or 95% or 100% of what Medicare allows. Can you furnish us with some data on maybe some programs that are far behind, in that 60, 70% rate that we could look at? And I just think it'd be easier for future legislators and programs to budget if they knew that they would have at least a minimum of, a certain percentage that the legislature would choose. Thank you.
Madam Chairman, Representative Clouston, absolutely, we can certainly provide our estimate there in a response memo.
Perfect. Thank you very much. Committee, any further questions for the department? All right. Anybody, excuse me. I think it's too early in the morning for my voice. Anybody in the room that would like to speak and testify on this subject, please come up and fill the chairs. Good morning. If you just give us your name for the record and give us your testimony.
Madam Chairman and members of the committee, my name is Amy Womack, and I am the Director of Grassroots Operations for Americans for Prosperity here in Wyoming. And on a personal note, I'm a breast cancer survivor, and this issue is very important to me. The U.S. is facing a critical shortage of physicians due to aging workforce and overburdensome license requirements. A way to mitigate this shortage is to provide international medical graduates, otherwise known as IMGs, that have trained in comparable programs outside the U.S. with a reasonable pathway to license as a physician. Medical licensing laws differ from state to state, but typically require physicians to graduate from an accredited medical school, pass a standardized test, and complete a residency program. This can last from 3 to 5 years depending on the specialty. IMGs are not exempt from residency program requirements, even if they have already completed that training and were practicing as a physician in another country. In the past several years, multiple states have reduced duplicate licensing requirements for IMG applicants. These new pathways to licensure allow IMGs to practice on time-limited provisional licenses under supervision of licensed physicians with the ability to apply for an unrestricted license to practice as an autonomous provider. Why this matters. Patients deserve greater access to quality health care. Licensing should protect patients without creating unnecessary barriers to entry. Competition and innovation strengthens healthcare systems. Healthcare policy should empower individuals and communities. And to conclude, it's important to note that the law would cost the state nothing, put no mandates in place, and the legislature has seen this issue for the last 2 years, but the House has ran out of time to act on the bill both times. Thank you, Madam Chairman and members of the committee.
Thank you very much, committee. Any questions? Yeah,
Madam Chair, yes, thank you. My question would be, under the supervision of a licensed physician, could that be an MD, a DO, whatever would be appropriate in there, or do they have to be an MD?
Madam Chairman and Senator Crum, I know the legislation last year that was provided, I don't see if it was an MD or a DO or that kind of thing, but those are all great options to get physicians here so that we can provide for the citizens of Wyoming.
Thank you, Madam Chairman. Yeah, just a comment would be, I would agree with that statement that it ought to be broad enough to take in the scope of people practicing within our communities. So thank you.
Representative Costin, and then we'll go to Representative Wasserberger.
Thank you, Madam Chair. So just last year in Labor and Health, we passed this through this committee on the House side, 9-0. It went through the floor in the House, 60-0. So Representative Wasserberger, myself, and Chairwoman Ottman co-sponsored this bill, and it was a medical doctor or similar profession. So DOs would have qualified. Yep.
Representative Wasserberger.
Thank you, Madam Chair. Thank you for coming and testifying today, Amy. Just maybe to hear from your guys' perception from the Americans for Prosperity chapter on this topic. I know that our medical board was talking about how it didn't do a significant change on bringing physicians in. I was just wondering, have you guys seen in other states where it's been a lot more significant as far as what impact it's brought to the community? Because I mean, I know it's probably not the ultimate solution, but it's just interesting hearing both sides of the spectrum on it and how much it could help the community and how it might just, we might have it for a source in our arsenal, but maybe it's just there for when we need it or if we need it. Have you seen in other areas where it's been pretty significant to the community?
Madam Chairman and Representative Wasserberger, yes. And I am happy to get you that information, the committee, the information that we've seen how it's worked in other states to be successful for citizens.
Thank you.
Representative Yen.
Madam Chairman, thank you. Ms. Womack, appreciate you joining us. It's always been interesting. I voted for the bill. I mean, I think I'm supportive of the concept. It's like Representative Wasserberger said, I don't think it's a solution to everything. It's always been interesting to me that Americans for Prosperity advocates for international doctors to come in. I'm curious if Americans for Prosperity has any ideas on increasing the crop of domestic doctors so we can have more prosperous Americans.
Madam Chairman and Representative Yin, yes, I can get back with you on that and visit with you on how we can brainstorm to see what we can do to have those type of programs that we can bring American doctors into the fold and see what regulations are in place that are hindering the licensing process. So would love to work with you on that.
Senator Scott.
Madam Chairman, my question is in terms of recruiting more doctors here to Wyoming. At times in the past, our problems with our tort liability system have been a major obstacle to recruiting in Wyoming. I think that's still true, just on a cost basis in the maternity area. But other than that, am I right in perceiving that that's not a major problem right now, or is it a problem?
Madam Chairman and Senator Scott, let me ask, are you asking if recruiting doctors specifically for Wyoming is still a problem?
No, as we try to recruit doctors for Wyoming, is our problems with our tort liability system, is that a major problem? Reason that they don't come here? I think because of cost, it is in the maternity area, but I don't know about the other areas.
Madam Chairman and Senator Scott, I know there are a lot of limitations for physicians coming here, not only for those reasons, but if they're married or things like that. But I would love to work with you and investigate that more. If we could get together, that would be super great and hear your thoughts on that. Thank you, Madam Chairman.
Co-chairman.
Thank you, Madam Co-Chairman. Hello, Ms. Womack. I didn't recognize you at first. That's why I didn't say so. Hello, thank you for coming. With this, yesterday we had the licensure board here, and one of the things that they were talking about was the incidents, like for a physician, how many cases might they have, and if they could keep their practice up to date. So are those any of the issues that you've been able to consider how that might work, whether they might fly in, whether they might be a part-time person, whether, however that might work, because I know we have a lot of cases and I know how important they are. I've had some of that in my family. But to get doctors here, do you have any suggestions on how that might work to keep them busy?
Thank you, Madam Chairman, Representative Ottoman. Yes, and we've been in discussions with other states who've implemented that have these kind of issues. And we can certainly work with what would fit for Wyoming and what that looks like. So I would love to have more discussions on that. So thank you. Thank you, Madam Chairman.
Any further questions for the committee? Okay, thank you very much. All right. Who would like to come next and talk about healthcare provider shortage and accessibility?
Morning,
Morning.
Madam Chair. Good morning, committee members. My name is Lance Porter. I'm the CEO of Banner Wyoming Medical Center. And I believe there was a question from Senator Scott that I'd like to respond to. The question was, if I understood correctly, what is the percentage of our payer mix that is Medicaid and Medicare? The answer to that for Banner Wyoming Medical Center is 45%. Medicaid makes up about 10%. So that payer mix is very important to us. I know of other more rural communities that have an aging population that percentage is actually north of there. But for Banner Wyoming Medical Center, it is 45%. There was an additional question of whether or not we could bill additional to Medicare over what they are willing to, or Medicare, over what they pay us. And the answer to that is no. With commercial payers, we're able to negotiate our contracts, but with Medicare, we get what they decide they're going to pay us. Critical access hospitals have the advantage of because they are critical to their communities, their reimbursement is based on their cost report. So the more space that they have designated to clinical versus office, things like that, they get more funding through the government for that. But for a PPS hospital like Wyoming Medical Center, we get what the government says, the rates that they set. There's no negotiations. Are there any questions?
Thank you. Senator Scott?
Is it Medicare and Medicaid, or is that just Medicare? And is that based on patient days or on volume of pain?
Madam Chair,
Can
Senator
we
Scott.
get that question repeated? We can't hear Senator Scott.
The question is what the 45% is, and is it based on patient days, or is it based on dollar volume?
Madam Chair, Senator Scott, 45% is, it's about 10% is Medicaid, 35% is Medicare, and it's the percentage of patients that have that coverage. And so I would say that most reimbursement for the hospitals does come from your commercial payers. Less of that, even though it's a larger percentage, comes from Medicare and Medicaid. As we go forward, it's a real challenge as we have an aging population. They're moving from commercial payment to a lesser paying Medicare rates. And so we still have the same population that needs more and more healthcare in a hospital, but the rates and the number of people covered by that are covered by Medicare. Growing concern across the country. Any other questions?
Committee, any further questions? I have a question. When you look at recruiting physicians to the state, and I think you touched a little bit on this yesterday, but what do you see as the biggest barriers to recruiting to this state? We'll start there.
Madam Chair, that's a very good question. I did talk yesterday about livability. Because again, we are competing with other states, other communities for all these physicians. There is a shortage of physicians across the country, and that's just going to get worse over the next 10 years. You look at a lot of times, I talked about call burden the other day, but it's also support. For example, if you were to recruit, say, a rheumatologist to this community, we'd be able to support one based on the community needs. Similar to pediatric specialists, we just don't have the volume of children to support pediatric specialists. But if you were to recruit one physician to a community, they're all by themselves. And oftentimes physicians don't like to be the sole authority for a certain specific specialty. They like to have a community around them. They like to have partners that they can rely on. So that does pose a challenge as well. And then it's also salaries. People are demanding higher and higher salaries these days, and it's a matter of matching that salary to what their expectations are. And then it's also culture. And can you create a medical staff where it's a healthy culture and they come and they feel again that they're part of a larger system rather than one specialty kind of just duking it out on their own. And so if you can create a healthy medical staff within your hospital, good nurses, good environment to work in, then you're going to be more successful in recruiting. Thank you. Any other questions?
Yeah, I think, no, I appreciate that. What are the reasons? And I know because I've worked with physicians before who have left because their families don't like it here, their wives don't like it here. And I can't change that we live in the desert and that we have nasty, windy winter days. I can't legislate that away, unfortunately. But besides that, what are things that you see people maybe come here 2-3 years, your physicians, and then they go other places? What are the reasons for the physicians leaving that you're seeing?
Madam Chair, thank you for that question. If I look back on it, yes, you're absolutely right. There's certain things we can't do anything about. It's the wind, it's the weather. People get tired of that. It's the spouse not being able to find a job. Often we will hire somebody who has a J-1 visa, which is nice because they're committed to a community for 3 years. But at the end of that, then they might start looking for a job in another state that has, especially for out of the country, they may look for, for example, if we recruit somebody from India, they may look to Denver where there's a larger population from their culture and not so much here in Casper. But what we have found also is sometimes we'll bring in a locums physician to fill a gap. For example, nobody likes locums, but if you have a vacancy in your emergency room, you just can't do without. You have to be open 24/7. You have to be fully staffed. And so sometimes locums are a necessity. But what we found is sometimes when we bring these physicians in, they love it here and they stick around. We had that recent opportunity with a couple of pulmonologists who worked here during COVID, helped us during a major crisis. They love this community and this hospital so much that they are now working here full time. So I think once people get here and they realize what a great community this is, we have a chance of recruiting them full time.
Thank you. How much do you see, we've kind of talked a little bit about tort reform and with a physician here yesterday that talked about, their, the liability and how, all of their stuff is really on the line when it comes to lawsuits and stuff. What do you hear about that? Or thoughts on how much of that is a burden to getting people here in Wyoming?
Madam Chair, thank you for that question. Where the biggest issue is with OBGYN. I have not had that be a barrier to recruitment for other specialties that I'm aware of. I can talk to our recruiters, though, who go through many more initial interviews and screenings, things like that, to see if that's a bigger problem that I'm aware of. But so far, I have personal experience with OB and that being a challenge, which is also why I invited Dr. Sheridan to be with us yesterday. Thank you.
All right. Thank you. And maybe can you just speak then, I think for the committee, and maybe we probably covered this before, but we'll go over just kind of what that liability looks like, why it looks different maybe for an OBGYN and why that would be a concern for them versus maybe a pulmonologist or cardiologist or something like that.
Madam Chair, I'm not an expert in malpractice, but I do know that when you're dealing with unexpected death, it is challenging in any situation. When you're talking about the unexpected death in an infant, a newborn, that parents have been waiting for 9 months, it is especially heartbreaking, and that often leads to more emotional responses, which then can lead to why did this happen, which often people will then look to a lawyer to help represent them, and it can be highly litigious. It's across the country. There are some states that have even a harder time recruiting than we do because of the litigious nature and the laws in their states.
Thank you.
Madam Chairman,
Senator Scott.
follow up on these last questions. Am I right in thinking that in many of the specialties, it's now not so much the doctor that's carrying the liability insurance, it's their employer? Is that a factor in the diminished importance of tort liability in many areas?
Madam Chair, Senator Scott, that's actually a very good question. In the case of an employed physician, that malpractice is carried by the employer. For example, Banner Health employed physicians, their malpractice is covered by Banner Health. Independent physicians, however, have to carry their own. And here, of our specialists, I would say about 60% are independent physicians, and that's your surgeons, specialists. Most of your primary care in Casper is employed. But yeah, your independent are the ones that carry the higher burden.
Any further? Representative Yin.
Madam Chairman, Mr. Porter, do you as a hospital have your recruiters develop some sort of report that documents all of the things when you interview people, why they say they don't want to accept an offer or anything like that? Because I assume that's, something that if a hospital could improve on any specific metric that someone says they don't want to show up here, they would do so, but hopefully you have things that we could work on as well.
Madam Chair, Representative Yin, that's a good question as well. And yes, we do. We have about a monthly meeting where we meet with our recruiters and we look at candidates that we have, where they are in their recruitment process and reasons why that weren't successful. Sometimes we'll never know. I think a lot of times we have candidates that are just shopping around, seeing what kind of opportunities there are, and then they just stop responding. And we'll never know why. But then what I've already responded to about reasons why people don't come here as part of that, that feedback from our recruiters.
Any further questions? Okay, thank you very much.
Thank you.
All right. Anybody else that would like to talk about? All right.
Thank you, Madam Chair.
Good
Good morning. Tony,
Welcome. Thank you.
Tony Decklever with the Wyoming Nurses Association. And so my talk is going to be focused on our nursing staff. Nurses include nursing assistants, registered nurses, licensed practical nurses. We don't have a lot of those, but they're part of our group, and advanced practice registered nurses. And so because we make up the largest sector of healthcare, we have the same issues as the physicians and behavioral health and all those that we're facing a shortage. And so our community colleges and our university, they have nursing programs, but it takes a while. So the community colleges, it's a minimum of a 2-year program, which is actually 3. And then the university is 4. APRNs go an additional 1 to 2 years and to specialize in an area. We're very fortunate in the state of Wyoming that advanced practice registered nurses have what we call full practice authority. So they are able to work in primary care. They can hang a shingle. They can see patients, and they can prescribe if they have prescriptive authority. So they fill a big void where we cannot get physicians. APRNs kind of are the go-to. The one area that is kind of a sticking point with a lot of our advanced practice registered nurses is that they are unable to admit to a hospital. And so we have a statute in Wyoming that says that they can't even submit the paperwork to a hospital. Now, there are some hospitals that do. They will accept an APRN application, and they will go through a credentialing process. But overall, APRNs have to be under a physician if they have a patient in the hospital. And so that's something that maybe we'd like to see change. That would take a legislative change to make that happen. And we're working with the Board of Nursing, and we'll work with the Medical Society and the WNA and the Advanced Practice Registered Nurse Group to try and work on some language that works for everybody. So at the lower level, we have nursing assistants, and nursing assistants are our primary healthcare professional or provider or direct care provider in long-term care facilities. And this level of caregiver, there is a tremendous shortage. And many of our long-term care facilities struggle to maintain proper staffing in order to take care of their residents. So they have to halt admissions to our long-term care facilities because they just don't have the nursing assistants to come and work. In order to be a CNA, they must take a class. It's a 75-hour minimum class. Then they must take a test, and that's a skill-based test and a written exam to receive the certification from the Board of Nursing. One of the challenges that we have is, well, it's twofold. In order to teach nursing assistants, the only people that can teach them are registered nurses that have been an RN for at least 1 year and have 1 year of long-term care facility services experience. So we have many, many, many nurses that would like to be instructors or to teach these CNAs, but they do not qualify. And unfortunately, that is a federal regulation. It's in the CFR. And I've been meeting with the Department of Health, and Laura Hutsmith of the Department of Health reached out to CMS to ask if that is so strict that you have to be an RN with long-term care facility experience. And is there any kind of give, you know? And so we're working with Department of Health as far as could that be broadened a little bit? The Life Resources Center is a long-term care facility. The state hospital is it can have patients that are there for a long time, and they use nurses and they use nursing assistants, but the nurses that work there are not qualified to teach the CNAs that are going to be working in their facility because they don't meet the qualification, even though it is kind of a long-term, it's not a nursing home. The Life Resource Center is not a nursing home. So it just is, it's a challenge. The other piece is all of our nursing schools have now required nursing assistant certification as a prerequisite to get into the nursing school, which is a great thing, except that our future nursing students are taking spots. They have no intention of working as a CNA, so they're taking the CNA spots in the courses that are offered, and then so they can use that as an entry criteria to get into nursing school. So it lessens the number of nursing assistants that we can teach, that we can test. The testing is also, it has to be done by a registered nurse, and so there's a shortage of that, and so it's kind of a cyclic kind of thing. The Wyoming, one of the things that came up yesterday was, getting people interested in healthcare. So one of the things that the university has done, and they did it last year, and they're doing it this year, is called gosh darn, what's that called? Scrubs to something. I'm sorry. But what it is it invites all of the high school kids from around the state to come to the university for a day, and they meet with different healthcare professionals, and they talk with folks, and they have little workshops, school to scrubs, that's it, school to scrubs. And they spend this day just kind of, visiting with healthcare professionals, because we know if we can get them interested at a younger age and not wait until they're already in college, that we have a better chance of funneling them into a healthcare profession. And so that's one of the things that, that's already in place. The Wyoming Center for Nursing is working on workplace or work data, trying to gather nursing demand and accessibility in our state. And so we have a young lady from LCCC who's gathering that kind of data, and we're working on that. The Wyoming Health Resources Network, I'm the president of, and my friend over here, she's a board member also for the Wyoming Health Resources Network. And we are a provider recruiting organization. And that is all we do right now, is recruit and get, and it's physicians, PAs, APRNs, and in some cases nurses. We've also added C-suite because sometimes those positions are difficult to recruit. And so we have an executive director who she is out there and she's talking to people and gathering information. She talks to WWAMI, she talks to the UW family residents, trying to get them to stay in Wyoming, come to Wyoming. And so that is her job, and that's all she does. And she works with the other hospitals, but the places like Banner and Cheyenne Regional, they are big and they have recruiters, but the little places, they can't afford a full-time recruiter. So they use WHRN to try and bring people in. So, You know, the Nurses Association, we work on policy. The center works on workforce. The Wyoming Health Resources Network works on recruitment. And so we've got a lot of things going on, but it's just a matter of, you know, getting people that are willing to work, getting some legislative support, getting community support to make all these things happen. I stand for any questions.
Well, thank you. You know, you learn something new every day. I just learned that even though I've been a nurse for 21 years, I could not teach a CNA class.
Correct.
Didn't know that. So, committee, any questions for Mrs. Ducklover? Senator Scott, is your hand up?
Yeah.
Okay, Senator Scott.
Two questions not very related. First, first one, in a number of settings, I've encountered a person whose name tag says medical assistant on it, and they act sort of like nurses. Who are those people? Do they have any credentials? That was a new one on me.
Okay.
Second question, in terms of retaining CNAs, it seems to me there that money talks. You've got to be competitive with what Walmart's paying for its employees. You've got to be competitive with a number of other things that way. Are we having a problem where we're not competitive, particularly in nursing homes? You know, the state is so much a share of their major share of their payments. Are we going to have to endanger the general fund by increasing the nursing home reimbursement so they can afford to hire the CNAs?
Madam Chair. So your first question, in the state of Wyoming, medical assistants are not recognized. They carry no certification, no licensure, no oversight in this state. Some states they do. There is no standardized curriculum like there is for nursing assistants and for registered nurses and LPNs. So there are some medical assistants that will take a course. Sometimes they're offered by community colleges. Sometimes they're offered by, you know, just independent entrepreneur kinds of teaching places. Or the physician or the provider can hire them off the street with no training and train them themselves, OJT. And so, and they call themselves MAs. They are taught procedural types of tasks that are relevant to the office that they work in. They generally only work in clinics or doctor's offices. We don't generally see them in long-term care. We don't see them in hospitals because they have no, they say, it says MA on their name tag, but, and they might have had some previous training, but they're not, they have no board that oversees them. Like we have the Board of Nursing and our PAs and our doctors have the Board of Medicine. They do not. And so if a doctor was displeased with an MA and wanted to terminate them, they could. There is no reporting that goes to anybody. They could just move on to the next place and off they go. So, and when you say that they present themselves as nurses, I mean, they come up because they do. That's when nurses, registered nurses like myself, we bristle because I have an advanced degree and I went to school for a long time to get my RN. And so when MAs come into a doc or meet with a patient and they don't have a name tag on and they don't identify themselves as MAs, the assumption is that they are a nurse. They are in scrubs, they've got a stethoscope on. And so many of our public are confused as to, is this a nurse or is this what is this person? And so, and I know the Medical Society at one time had tried to do this transparency in people wearing name tags and wearing, and signs so that the public could understand the type of provider that is in front of them. And I've had MAs in front of me and they tell me things and I'm like, I don't think so, because they're valuable person in a clinic or a doctor's office because they're the ones that admit you, they take your vital signs, they weigh you, they can do an EKG, they can do a urine test, they do procedural kinds of things, and they're very, very helpful. But they need to, they need to be identified as an MA and not an RN or an LPN. And the public is a little bit confused by that. The other thing that our system is it is confusing, but a nursing assistant who has gone through the 75-hour CNA course and has worked for a year as a CNA can take additional training and become a CNA 2. And a CNA 2 can do some treatments and different procedural things inside of a long-term care facility. A person that does that wants to go on and get more training as a MAC, which is medication assistant, not medical assistant, medication assistant certified. So they get an additional certification on their CNA that allows them to pass medications in a long-term care facility. And the RN always has oversight over this, but they are able to give residents common and predictable medications. And so it just helps the nurses. Long-term care facility residents, on average, each person takes 9 medications a day. And so the medication load is a lot. And some nurses, that's all they're doing is just passing meds all day long. So having a MAC, they go through the Board of Nursing because there's a CNA, so they're overseen by the Board of Nursing. They are another level that can be helpful in a long-term care facility, and some folks do use those. So your second question, Senator Scott, as far as pay. The pay is actually in some facilities pretty comparable. I mean, they're working really hard to get the pay up for our nursing assistants, though it's an entry-level position, so it ranks right there with things like Walmart and other places like that. But CNA work is hard. You're dealing with are the sickest and most vulnerable of our population. They're elderly, they have dementia, they're difficult patients to take care of, and it's shift work. And so they're working 365, 24 hours, and so they're working holidays and nights, and so it's a tough environment. And when I was a director of nursing for a long-term care facility, and I would have people coming in and out, in and out, in and out, what I found was that it wasn't so much pay. Pay is important, but it's the environment. Do these people feel respected and valued? And if they don't, they are going to leave in a heartbeat, and they are going to go to some place that treats them well. And so I mean, it truly is the number one reason why people leave their job is not the job itself, as long as the pay is decent. It's the environment. It's the people that they work with and how they're treated and all that other stuff. And so, if we can, I don't know, if we can just make people a little bit more kinder and patient, that might help a lot. But kind of like legislating the wind. I mean, it's kind of difficult. So. Did that answer
Any
your
follow-up
question?
questions? All right, thank you. I was getting, no, there is, Representative Thayer has a question.
Thank you, Madam Co-Chair. Thank you, Tony, for being here today. This has been very informative. And this may be a loaded question, but I'm going to, with the limited number of spots for nursing schools due to faculty and sites, and like you just talked about at long-term care, in 2026, I think my stats are correct, there were 48 students that were enrolled in the nursing program with 120 to 200 applications. I know the brand program, financial aid, there's been some changes and some good things happening. But again, here might be my loaded question is, thinking outside the box, Tony, are there any ideas or things that we can do to help, like Madam Co-Chair said, she can't be an instructor for LTC, but we're not even having spots. I mean, I personally know there are 3 individuals here in Hardeman County that wanted to go to nursing school and they were not able to get in. So shortages are continuing. Any outside the box ideas?
Madam Chair, and Representative Thayer, thank you. It's an ongoing challenge for sure. the schools are bound by faculty to student ratios. And they can only have 8 students per faculty member. So depending on how much faculty they have, they could increase the number of students. But in order to teach, you have to have an advanced degree. Now, you have to have a master's in nursing education. You can be an APRN, but you have to have the advanced degree. And just like so many places, and they talked about University of Wyoming faculty, faculty pay at the community colleges is not as much as they would make in the private sector. So now it's it's hours in lieu of pay. So the job requirement, the work hours, and those kinds of things, those are different if you're in a educational setting versus in a facility setting, for sure. So some people are willing to take the cut and pay because it's a better lifestyle. But even if we had a lot of faculty, the other challenge, and I know you've heard this, is clinical sites. Because the nurses have to do a clinical rotation, and so they need clinical sites. Well, in order to have clinical experience, you have to have patients. And so when you have very, very small communities that maybe only have one critical access hospital that maybe only has 8 patients that day, maybe 10, they can't put 8 or 10 nursing students in there because they just can't get a good clinical experience. So that is definitely a challenge. One of the things that, and I don't know if this could be done legislatively or not, but we do have out-of-state schools that use our facilities for their clinical sites. And it's only anecdotal. I have no data to support it. But the frustration is that we can't get clinical sites for our own people because they're being taken up by people from out-of-state schools, because they need clinical sites too. And so it's kind of it's an ongoing thing. We're working on that because the Nurses Association, the Wyoming Center for Nurses, we recognize that this is a big problem, and we're trying. But to increase nursing faculty pay to get more faculty, the community colleges can't do that because they can't just raise one group's pay, because the math teacher is just as important as the chemistry teacher, is just as important as the ag teacher. And so to say, well, we need nurses, well, we also need all these other people too. So, so it does become quite the challenge.
Follow up.
Follow up.
Thank you, Madam Chairman. Thank you, Tony. Those were thank you. I appreciate those thoughts of the out-of-state school spots and pay and ratio for faculty. Thank you.
You're welcome.
And I believe some of those out of state that are have clinical spots within the state, it's a pay thing, like they're paying more to the hospitals for those clinical spots, I believe. Am I correct in?
Madam Chair, you are correct.
Okay.
Yeah.
That's what I had heard.
Money talks.
Okay. Committee, any further questions?
Thank you.
Okay, thank you. Welcome.
Good morning. Members of the committee, Madam Chairman, Sheila Bush with the Wyoming Medical Society again. We touched on some of these numbers yesterday, but I wanted to reiterate a couple of them and offer some new ones and a few thoughts and ideas. So just for a little bit of data, which I'd like to also talk about, Wyoming approximately has 1,500 physicians licensed that we believe are actively practicing medicine here in Wyoming, meaning for us that they live and work here, they get up in the morning and see Wyoming patients. 180 physicians per 100,000 is what our average here in Wyoming is. For context, the national average is 248 physicians per 100,000. And we have 65 primary care physicians in Wyoming per 100,000, and the national average is 94 primary care physicians per 100,000. The mean age of Wyoming practicing physicians was 53 years, but that is 2021 data. So I don't have anything more recent. But it does seem pretty consistent. Way back when I was brand new at this job and we had a healthcare commission, they did a really robust analysis of the physician community and population. And I remember in 2008, the average age of the physician at that time was 55. So in 2021, 53 is a little younger, but it's not super young. It's not really old, but it's not young. In that same year, so in 2021, women comprised 26% of the physician workforce here in the state of Wyoming. It's estimated that 10% of Wyoming's physician workforce completed their residency here in Wyoming, and 15% completed their residency in one of our WWAMI states and then returned here to practice. The reason I wanted to talk about data a little bit is that we don't do a great job with data in Wyoming. When this topic was put on the agenda, the medical society should be able to give you really, really good current data. And we're left with trying to kind of bring pieces and parts together from national data, from the AMA, from workforce services, licensure data, which Director Bonenbless talked about is a little hard. He had more than 8,000 licensees. Not all of those practice here. Some are telehealth. We also have a number of retired physicians who maintain an active license for a variety of reasons. And so it makes it really hard when we go to do this sort of data analysis to give you an idea of who we think the physicians in Wyoming are. We take birth year, and then we try to say, like, assuming if you're 80, it's not likely that you're full-time anymore. But that's a kind of stab in the dark because we do have a lot of active licenses that are in a more aging part of that community that you just have to make assumptions about, and we all know how dangerous those assumptions can be. As I said yesterday, licensure is only a part of that picture. I think if those physicians aren't contracted to be in network with our payers, that doesn't actually equate to a provider who's available to provide care in those communities. And so I think one win for Wyoming would be putting a little bit of conversation and investment around data collection, bringing all of these things together, not just for physicians, but across healthcare. The only way that you all can make really educated decisions is if you have good data and if you're working with a solid set of facts that are the same and that can be trusted, rather than all of us doing our best to pull that data. But like I said, a lot of the data I found is from 2021. The University of Washington, AHEC, they do a big workforce study that was most recently done also in 2021. The AMA has a workforce mapper that anybody can go on. It's an interactive map, also not super user-friendly. But once you get in it, that data is, again, it's 2021. I don't know what kind of magic happened in 2021, but we haven't done anything with that since. And so for a private organization to try and do surveys, and it's really expensive. It takes a lot of staff time, and we don't really have that. And so I think one ask I would have as this conversation continues and we continue to try to tackle this problem together is identifying a way to get really good data that we can trust. The Healthcare Commission was charged with that when we had one. As you all know, we don't have a Healthcare Commission right now, but it was a really key piece of some of the work that they did, and it was something that we all kind of collectively relied on that mattered a lot. So moving on, I think one of the problems that we see with workforce is a devaluing of primary care through time. That's not just a state problem, that's across the country. Primary care it plays such a critical role in the healthcare of our communities. And so just quickly to kind of give you an idea, it's the only healthcare component where then increased supply is associated directly with better population health and more equitable outcomes. In the US, an increase of one PCP or primary care physician per 10,000 people found a decrease in both infant and adult mortality and a 3.2% reduction in low birth weight. Patients with a long-term relationship with a PCP are less likely to visit an emergency department, which we all know is the very most expensive door into healthcare. US adults with a PCP had a 33% lower healthcare cost overall. Despite the significant role that primary care plays in our healthcare system, primary care accounts for only 5 to 7% of our total healthcare spending in the United States. So they're the front line. They're the physician specialty that we expect to know tip to toe, A to Z, diagnose, this is not a problem or this is a problem. They're the ones deciding if you need a referral. They're such a critical component of the fabric that makes healthcare, and we spend 5 to 7% on them. And I think that matters. The US on average spends half the amount as other industrialized nations on primary care as a percentage of our total healthcare spend. 13 states recently have enacted legislation or taken a regulatory move to measure spending on primary care. 8 of those 13 states, as a result of some of that study, went further and set spending targets. Increasing spending on primary care by 3.4% over 4 years, this is from the state of Rhode Island, saw a 14% decline in healthcare expenditures. So the evidence is pretty clear, and the data speaks for itself, I think, in the role that primary care plays. So I wanted to address, I know tort reform and liability has come up a lot the last couple of days. The Medical Society has been a long champion of tort reform and trying to ease the burden of liability on our physician community. As you all know, there are 12 states in the country, Wyoming is one of them, who have a constitutional prohibition on capping non-economic damages. The last time Wyoming tried to change that was in 2004. It narrowly failed on a ballot measure. The other component that was on the ballot in 2004 was a medical review panel. That one passed. We dispensed with the medical review panel in the late teens. I don't remember the year exactly. It wasn't utilized the way that we had hoped it would be. It didn't have a lot of strength. It didn't have any teeth. We realized as we got into it that it was being used as a forum for one party or the other to basically just get discovery from the other. But because it wasn't binding and none of the decisions there, I think even the physician medical defense attorneys were advising them to either not participate or there was some gaming with timelines in it that I don't recall exactly. But there was a reason that we dispensed with it. And so I think one option, because we did have the ballot initiative and there is a pathway available, that law was fully repealed, but there is precedent. It's maybe worth a conversation. I know Senator Scott would have a better memory than mine, sir, for how all of that worked and what that medical review panel's journey felt like. But it's something that we could maybe see if other states have done it better. I know yesterday Dr. Sheridan referenced Montana. I think that there are examples of states who do medical review panels or sort of pretrial vetting entities better than maybe Wyoming did ours. The other thing, Utah has a law that I am still at the beginning of really understanding fully, and I look forward to kind of discussing with you in more detail as the summer progresses. But it's a form of a shield law that protects physicians' personal assets. And so I think that there's a lot of merit there. I think that the physician community in Utah is very excited about what that looked like and what that means for their protections. I think when we talk about scope of practice, and Dr. Sheridan spoke to it yesterday, I spoke to the fragmentation aspect of scope expansions and what those conversations look like. The other thing is when you allow a lot of different professions to do different parts of procedures or diagnoses, you increase the liability. As you ratchet up on the training scale, if mistakes happen or things are missed early, it increases the liability burden for the physicians further down the line that are catching those problems. So it is a direct consequence to expanding scope, which Wyoming has done a lot of. There are very few professions left to expand the scope for. So I think we're going to continue to see some of the consequences of those decisions. Volume is going to be a piece of access. As patient volume increases, then increases the ability for us to hire and sustain providers. This has been talked about at length yesterday and today. But physicians, especially in the specialties and particularly in surgical specialties, want to have enough volume to maintain quality. And so if our smaller communities want to maintain some of those specialties where we lack the volume, Wyoming should have meaningful conversations about how we can support hospitals or systems to allow sort of transfer programs. I know Eric Boley has spoke in the past about his former hospital over on the western side of the state, where they would allow physicians to travel to another state and get high acuity, spend a few weeks doing some of those cases so that they can come home. They feel like they're maintaining volume. They're getting that procedure count up. Same for nurses. I know that when a particular community in our state closed their OB line, yes, it was financial, there were strains, but the other piece of it that didn't get talked about as much was, I think they averaged 43 births a year. That's not enough for that community, the nurses and the physicians, to feel like they are well-equipped to handle a really bad outcome. And so I think that a meaningful conversation around what some of those transfer or sort of, I don't know, exchange programs might look like for doctors and nurses would be helpful. Finally, I think just some solutions. I think it might be time, as we come up on the 30-year anniversary of WWAMI, to look at the residency requirements. It's possible that they're just a little too strict. I know in my personal experience in the last couple of years, there have been a handful of individuals, one of whom was my son's hockey coach, who would have been a beautiful fit for WWAMI, had big heart ties to this state, had an aunt who was a dermatologist in the state, an ideal candidate, and he didn't qualify. We also have some trouble. We had students that leave for their undergraduate degree, so they went to high school, their families are here, they were raised here in Wyoming. For whatever reason, during their undergraduate lives, they got a license or an ID in another state, and that created some problems for them applying for WWAMI because they didn't hold an ID in Wyoming. Little things that maybe could be solved and some bigger things that might deserve a conversation. WWAMI has been a wild success. We're incredibly proud of WWAMI and what it's supposed to do and what it has done. But I think a conversation about what those residency requirements look like would be in order. I think investment in our residency programs, I've talked a lot about this, particularly with Senator Scott. I said most of this yesterday, so we'll try to not repeat myself, but our residencies really matter, and especially when you look at the primary care workforce and the role that those residencies are playing in developing that workforce. I think that, you know, remembering to invest in those is a really good idea. Our loan repayment program could use some funding. The skeleton is there. We haven't done a great job of funding it. The state of Arizona, they are giving students $65,000 a year to repay their student loans for the first 2 years of service in the state of Arizona, and $35,000 a year for every subsequent year until their loans are paid off for the service that they do in Arizona. I believe in Arizona there are some requirements. They have to go to underserved areas. They can't go to it, they can't be in Phoenix and get some of those loan repayments, but if they go to more rural areas, I will fact check myself on that. And if I've misspoken, I will let you know. But I do think Arizona is one of the states that has some requirements around that loan repayment. Wisconsin has some really impressive loan repayment options, especially for family medicine, as does Colorado. And then I guess finally, Medicaid reimbursement, which you've heard about, but we know that in Wyoming, 87% of our primary care workforce participate in Medicare. 78% are accepting new Medicare patients. 60% of them are accepting new Medicaid patients. And those numbers directly correlate often to what they're able to recoup and get reimbursed to keep doors open in some of these private clinics. With that, I'll stand for questions.
Awesome. I'm just going to start off by, you gave us a lot of great data points. Would you?
Page 21.
Yeah, from 2021. But it's better than nothing. Hopefully. Would you mind sending all of those data things? I didn't write it all down because I was like, let's just ask for that. So if you would just send us all those data points, that would be great. And then Senator Scott, I believe you have some questions.
Yes, as Madam Chairman, some questions and some comments. That was extraordinarily useful.
Thank
And I think the evidence on the value of primary care. I do have one question on the data there. You said 5 to 7% of what? Was it total healthcare spending? Was it total reimbursement? What was that 5 to 7% of?
Madam Chairman, Senator Scott, it was 5 to 7% of the total healthcare spending in the United States. And I will send you all a link that came from the American Academy of Family Physicians, I believe. And it's this report that I pulled. So I will send LSO staff and Senator Scott, you can have my paper copy if you'd like.
Can you follow up?
Madam Chairman, a couple of other points on the reimbursement of primary care. Am I right in thinking that a major source of the problem there is the federal CMS payment schedules, that they develop their payment schedules using committees which are dominated by specialists and have pushed the specialist reimbursement at the expense of the primary care? And this has been widely copied by the private insurance companies. Am I right in thinking that that's a major source of our problem there?
Madam Chairman, you may have more expertise in that than me, Senator Scott. I could ask. It feels subjective. I don't know. It depends on, I think, your viewpoint of whether it's skewed one way or the other. And I'd hate to take a guess for fear of upsetting someone because I don't have a factual basis on which I am able to answer that. I'm sorry.
Yeah. Madam Chairman, there was mention of the pretrial screening panel that didn't work in this state. The purpose of a pretrial screening panel would be to try to get rid of a lot of malpractice cases early in the process, because those things almost never go to trial because it's too expensive to have a court case. And what they're really doing is extorting settlements. And if you can get rid of unfounded cases early, that cuts down the extorted settlements. I don't know that we couldn't, when we tried before, find a way to put good teeth in that our court system wouldn't just throw out. That's the problem we've got there. And if somebody has a creative solution to that, it'd be a good idea. But the way our courts are appointed, they tend to be hostile to something that might cut down lawyers' income. So that's a problem there. Madam Chairman, I think we ought to get LSO to find out exactly what Utah is doing in this shield law for personal assets. That might run afoul of our constitutional limitation on putting any kind of recovery on damages, but it might not. And that might be something we heard about that yesterday. And I'm told that malpractice insurance just isn't available when you go beyond the 1 million, 3 million category, that the insurance companies just won't sell. I don't know whether that's true or not, but that could be a major reform if that could work in Wyoming constitutionally. And I look forward to your information because it's extraordinarily valuable.
Representative Rodriguez-Williams.
Thank you, Madam Chair. Ms. Bush, thanks for being here. You mentioned the topic of scope expansions a little bit and the increase of liability that it perhaps poses. I kind of get the sense of lack of support perhaps, or a little bit of gloom on that. Curious, I mean, yesterday we talked about a lot of different proposals when it comes to scope expansion, when it comes to our pharmacists, dental hygienists, et cetera. Just curious if you've polled your members already on their opinion on those that were brought before the committee, or if you plan to.
Madam Chairman, I'm trying to think, we wouldn't poll our members on dental hygienists. That's not something that really touches medicine directly. As far as pharmacists, we haven't polled them because I don't have a bill. And I think our board anyway has tried to remain really thoughtful because pharmacy is such a critical partner of theirs. And so we don't want to overspeak, and we never want to be perceived. And I know historically we have been perceived as an organization that will just say no matter what. And I would offer that hasn't been the case, but perception can sometimes get skewed. And so I think we want to remain partners, and we want to remain at the table, and we don't want to just say no. I think it makes them really nervous. An example that I would give, and I think is pretty benign, although it's about something that has more controversy around it, I guess. But there was a proposal in this year's bill to reduce the age that a pharmacist can vaccinate a child, right? And I think right now it's 7, and the proposal was to reduce it to 3. And so I think there's more to when physicians, particularly pediatricians and family physicians, balk a little or have some gloom, which I like that term a lot, about that. It isn't necessarily about the actual administration of a vaccine to a 3-year-old, as much as it is for many of these families, that is the one time that they are in the physician's office that year. And it's the opportunity for them to talk about diet and nutrition and sleep habits and how things are going and other normal developmental things that should be happening by the time an individual has reached the age of 3. And if those things haven't happened, and if they should refer to occupational therapy, those kinds of things, that wraparound care is what our pediatric and family physician community is hoping will happen. And sometimes life gets really busy. And sometimes you just go, oh my gosh, it's been a year. And it's the vaccine alert, or it's something that normally happens that says, oh, I should make that appointment. I have to get in. And then those other conversations happen and things get caught. And I think it's that nuance, and it's that whole picture that's so important to the physician community. And so to say, oh, the medical society doesn't want them to vaccinate 3-year-olds. It's not because we don't think that pharmacists can't vaccinate a 3-year-old. That sounds condescending, and that's not our intent. It's just that so much else happens that's triggered by a vaccine appointment that then happens in the rest of the visit. And so if you sensed gloom, you probably sensed like a little bit of PTSD from me. Scope fights are traumatic. They're really hard. I've been at the Medical Society for 20 years. I've endured, survived a number of them. They're personal, they're sensitive. No matter how you have the conversation, someone takes offense because they believe that you're discrediting their education and their expertise, which is not the case. But no matter how kind you try to be and how many times you do the words in your head, someone's going to hear them that way. So they're just really hard. And I think we believe strongly in team-based care, and that all the members of the healthcare team are really important, but that the more that they're siloed, or the more that one is able to do that would normally have been a partnership with the other, the more risk that comes with that. I've learned about, I hadn't been in this job too long, and I was looking for an expert physician to come testify in front of this committee on some issue. I think it was, I don't even remember. And what I learned is the more educated and the more subspecialized, the quicker a physician, that's my world, I know physicians the best, is to say, nope, that's not my area of expertise. And it was interesting because we were able to find another healthcare professional who was eager to come give their expert testimony who had far less training. And I went to a community of people who had 14, 15, 16 years of schooling. And the higher you go, the quicker they were to say, oh gosh, that's not my lane. And I don't know if Senator Brennan can also speak to this in a hospital setting, but it's really common that you find the more expertise they have, it's almost like it's the more that they know they don't know. And the more you know, the more you don't, the more you know, the more that you know you don't know. And that sounds really silly. And as the words come out, I'm like, that doesn't work out. But it really is true. And so the less you know, the less you don't know what you don't know. And that's where things get really dangerous. And so gloom, maybe, I don't know. I hope not. But yeah, scope is really tricky. And they're just really hard issues.
Thank you for that question and that response. And that's kind of a great segue into my question and kind of my thoughts, because I think nobody in the medical community, I think, would argue that every piece doesn't have a part to play in that. And I think of, with my background in the ICU, we do interdisciplinary rounds, and how that whole team of people from, your CNA, your nurse, your respiratory therapist, your OTs, your PTs, your physician, even social worker, chaplain, like everybody has a part to play, I think, in the healthcare of the people in Wyoming and in our communities. And so with that, it was mentioned that the advanced practice nurses can't admit to the hospital. And I don't want to necessarily put you on the spot today, because I know that kind of these, where can people and what do those practices, they do get personal. I've seen that through in my whole career. They get personal and they disagree. One of my best friends is a physician, and we have different thoughts, and we discuss it and talk about it, and then move on to what are our kids doing this weekend, that kind of thing. But when we look at that, everybody does have a place to play. I guess I don't know if you have any thoughts today about them being able to admit to the hospital, what that might look like. But I do think that that is a conversation that would be maybe worth having. And so, my bigger ask is to kind of go back to your members, if you don't have an answer today, but if you have something that you want to speak to, that would be great too.
Sure. So it's not the first time that topic has come up. And historically, the position of the Medical Society has been that each individual hospital can make their own decisions about that. So there are hospitals in Wyoming that allow nurse practitioners to admit. And it all varies on if they can admit, and then within a certain number of hours, a physician has to review the chart and then have an extra sign off. I know some of our smaller hospitals, it's a much longer period of time that a nurse practitioner can do that admission. And then I think it's further out that, and I don't know if the Hospital Association maybe has this, or if Ms. Decklever. I know in our bigger hospitals, it's less. I think at CRMC, there is not any there isn't a lane for a nurse practitioner to admit in Cheyenne. And I think a lot depends on the availability of the workforce and what each unique community needs and what works best in those communities. And so our position has always been one of really stressing local control and allowing those individual communities and the hospitals within them to decide what works best for their community and who they have available to do those admissions, and what the hospital feels comfortable allowing. And honestly, what each individual hospital's insurance and liability space also would permit, or what keeps them safe as a facility. And so I will absolutely go back. I think it has been a few years since the Medical Society has talked about that issue. But the few times that it's come up in my tenure, The answer has always been the same, which is they don't think that one blanket statewide law is appropriate because it's not appropriate in from one facility to the next might not be the same.
Perfect. Thank you very much. I have this idea too of regionalized care has come up, I think, kind of a couple times through these meetings. Do you or your members have any idea of what that regionalized care might look like?
Madam Chairman, I don't. We talk about it a lot. The idea of regionalization brings big feelings. It brings fear. We have a couple of examples in our state of communities that were very close to each other, that both had hospitals that attempted to do what I would think of in terms of regionalization, and it didn't work out well at all for those communities. It created a lot of fighting. The physicians are still mad at each other. The hospitals are mad at each other. Now you have another hospital coming up as a result of some of the fighting, right? Like, I will also say in that same breath, I think it's going to be one of the only tools that we have available to us if we don't want to, at some point in the not too distant future, be a state that's only prepared to patch and ship. And I think that that's really bad. I think that today, Wyoming is on a superhighway to a destination of only being able to really like stabilize and get our patients out to another surrounding state facility. And I don't think that's good for our people. There's a lot of data about people being healthier when they can get care close to home, that they heal faster. There's so much benefit to being able to stay close to home. And I don't know if it's true anymore, but it used to be a saying that 70% of Wyoming's population lived within 70 miles of a border. And we have major hospital systems right on the edge of all of those borders, which we need. They're really important. But we also need that care here. And so regionalization continues to come up as an idea, because if you take a really small community and you try to put let's just talk about maternal care, right? So you can't put one OB there. You've got to at least have two if you don't want to burn them out just as quickly as possible. And if you don't have the volume to support the quality for two OBs, and you don't have that volume to financially support two OBs, then you've got to figure out, so I think it's Rollins that averaged 43 births a year before they closed. And I'd love to be corrected if I'm wrong. That's just me going from memory. But the state of Alaska does have a regionalization schema that works really well for them. Not everybody agrees with it. Not even in my own membership do they agree with it. But the way Alaska does, they have discovered a way to stratify risk. There are islands that are very remote that require plane rides. And Alaska's done a beautiful job of identifying pretty early who of those moms can safely deliver on their home island. Sometimes with a midwife, sometimes, with some level of care. And they've then identified those that are just not going to be safe. And so those get flown to Anchorage. They're provided housing. I think it's a physician team and a care team that decides how many weeks in advance of a due date that they needed to be located to somewhere with higher level care. I believe that the state of Alaska provides some level of salary stipend or subsidy so that the partner can fly with the individual. They safely deliver, they have a baby, they make sure everything's safe, and they fly back to their island. And so I think there's a lot to learn from Alaska. I do offer that with like an asterisk caveat. Not even everybody in my own world thinks that it's great. Alaska also has the advantage of they're a pretty closed loop system, right? They're different than us in a variety of ways. But that doesn't mean that they haven't gotten some wins that we could learn from. But your question is regionalization. I don't know. I know that it's a very emotional word for a lot of people. It's a politically sensitive word for a lot of people. But I think if groups like ours don't have a really intentional conversation about it being a meaningful option, The other option is not having care really here at all. And I don't think that that's good.
Well, thank you. I appreciate those thoughts in maybe staff, if you could, or if you have the information, if you could work with and just get us some of those things for Alaska. We've got similarities and we've got some big differences, but maybe there's some things that we could pick out there. I just want to comment, when you come to with regionalization, you use the words Appalachianship state or Appalachianship. And that hits home for me because that is a lot of what we do, what we see. Where I work, since I work at one of our larger, I see we get a lot of patients that are patched and shipped to us from other spots in the state because they don't have that ability. And so they get sent here or sent to Cheyenne, where we have kind of that higher level of care. But we also do our fair share of shipping patients out because we don't have that level of care. And I think sometimes it's very appropriate, and that even if we regionalized, we would still be doing some of that. But I think there's other times where, can you get that care closer to home? Because we do know that that is a good thing. You also talked about transfer programs or like exchange programs. That is actually something I'm learning a whole lot today. And this is like what I live and breathe outside of legislature is healthcare. And so this idea it does intrigue me. What do you see as possibly like the state's role in doing this? I mean, I know, I think even in the ICU where I work, we have cardiothoracic surgeons, and so we do a lot of open hearts and stuff. But I think we've even talked about like having an exchange program at one point. We've never done it, just to get a little bit more volume, because there is a volume thing on some of these. We feel very comfortable with, because doing, even if it's low volume, and other things are a little bit higher risk and low volume. And so there is something to be said about keeping some of those skills sharp.
Madam Chairman, I don't know exactly what the legislative role would be. I think that there's a lot to be learned from the private sector. Banner Health does a really nice job of this. In fact, Warland is going to have an FMOB, or does now, because of the investment that they're making in that individual, and an exchange program with one of their facilities in Arizona. And I know that there's folks in the rooms that can speak far better to that. But it is a win for our state. I know Dr. Beveridge shared that story with you a couple of years ago in the August 24 hearing about what a win he thought that was. I don't know exactly, except what I do know is there's so much opportunity in our state. We're pretty small. We do have the means to prioritize the things that matter most and then invest in them the right way. We're smaller than some states would consider a pilot project. Sorry. And so there's a lot of opportunity, and we have the ability to try some things. And if it doesn't work perfectly, we're not out so much that it's the end of the world. We can sort of adjust and pivot because we do have such a small population. And so while there are challenges, and that's what you've heard, I also think there's so much opportunity, and you've got really smart people who want to make those opportunities a reality. So I don't have an answer to you exactly what that looks like. I know Eric Boley testified at some point that when he was at his hospital, they were doing that, or maybe his hospital is doing that. And so there's likely someone within the hospital association membership that could speak more to that and talk about if they're doing it. I think it's on the western side of the state. But someone with more information about it than me would be great.
Perfect. I appreciate that. I think the last thing, yes, Representative Wasserberger.
Thank you, Madam Chair. Yeah, thank you for being here today, Ms. Bush. Representative Thayer brought up a really good point earlier about folks getting accepted into some of these programs. Do you know what the most common reason people don't get accepted into like the nursing program and things like that?
Madam Chairman. Representative Wasserberger, I can't speak to the nursing numbers. I don't know. And I honestly, even if your question was about like, why do kids make it or not make it into Wyoming, I don't know that I would be able to answer that. I know it's a combination of test scores, grades. For medical school, it's also how much shadowing they did. And then their interview is a huge piece. And then I know on top of all of that, for every medical school in WWAMI for Wyoming, another component that can differentiate one student from another getting accepted is how much that committee feels that student has demonstrated their willingness and genuine interest in coming back and making Wyoming their home. I think WWAMI takes very seriously their direction from the legislature and the investment being made in that program, that it really is intended to grow our own and bring those doctors back here. And so it's from the interview process throughout, it's a very common thread that is stressed with those students. And so I know that that's one of, you can have two top-notch kids, top scores, best grades, shadowed everybody. If one doesn't really have an interest, or they just kind of say the words, but they land hollow, and one kid is absolutely coming back here, I think that can sometimes differentiate students.
Thank you. Senator Scott.
In terms of physicians, students coming back to practice in Wyoming, it's around 50%, is it not?
Madam Chairman, I believe it's actually higher. It's between 60 and 65% return rate for WWAMI.
Madam Chairman, I think that is an extraordinarily high yield from a medical school program when you look across the sweep of the country. And so the people that are running the admissions committee and the people that are running the program are doing something right.
Thanks.
Mm-hmm. Any other questions right now?
If
I
there
have
aren't any
one.
others, sorry.
Oh, no, go ahead. No.
I was just going to offer, previous testimony was about the interest in continuing pursuing licensing of international medical graduates or international physicians. The Medical Society has been neutral or supportive of that. We have a couple of members, one of which is on our board, who was internationally trained, who's very supportive of the concept. One thing that I have, I think in the years that that bill has come, asked for the proponents or the bringers to include, the state of Arizona includes a list of countries that those graduates can come from. And we've always felt like that is a really, really good idea, especially as we're at the beginning of this. Not all countries have the same standards as the United States for educating medical graduates. And they don't have a similar system where you can do background checks and understand. I mean, they don't have the same robust government to be able to really know everything that we would like to know about an individual before we give them a medical license in the United States. I would commend Representative Wasserberger and all the work you did. It was a really good bill. And I know you partnered with the Board of Medicine. And so I think this year's bill was a really good one. I think it is important for the Medical Society, and something that we've kind of consistently asked for is to list the countries. And so Arizona, the countries that they list in case it matters, and I can also provide this information, is Australia, Canada, Hong Kong, Ireland, Israel, New Zealand, Singapore, South Africa, Switzerland, and the United Kingdom are the countries that are permitted for the state of Arizona. And whether those would be our countries or not, I can't speak to that. But I do think that the standard is a really good idea, and listing those countries adds another layer of security that would be really good.
Perfect. Thank you. I appreciate that. Maybe if you could send that to our LSO staff and maybe look at if there's other states that have some of those requirements and what those countries would be. And then the other thing that I would be curious if you could get some information, and if LSO could look at, is that loan repayment program. And you talked about Arizona, Wisconsin, and Colorado and what they do on that loan repayment for physicians. I know we do a great job of getting physicians here for, or what I see. I can't speak to statewide, but what I see is we get physicians here for that first like 3 years, and then they, for whatever reasons,
they'll end up leaving the state. Sometimes it is their families. I've worked with a lot of great physicians where the physicians love it here and their wives are like, I need a bigger city. I don't know if they need shopping or restaurants or away from the wind, but they don't like that. But there's other times that I think, and maybe you could ask and talk to your physicians, but I do think that looking at loan repayment, it costs a lot of money to go to medical school. And while physicians do make a lot of money, that it's a large portion of their paycheck, which I think is why we see not as many, just this turnout of not as much, where we're going into sort of an all-out shortage in medical care, including in physicians, it's costly. It's a lot of time, a lot of expense. So, and I think Senator Scott has a question.
Madam Chairman, not a question, but a comment. The loan repayment, we've had a good program here. The loan repayment program has, I think almost universally, been an effective means of recruiting. You have to get them when they're first starting out in practice and they're scared about their ability to pay those loans off, because after they get some experience, they don't get nearly as frightened as they are at the outset. But it has been effective. Madam Chairman, the name of the problem with the loan repayment committee, loan repayment system, is the appropriations committee. That's been a favorite target of theirs to cut back, and it's an effective program, but politically, that's where our problem is.
I would also offer that other states have identified what good physicians WWAMI is producing. And so it's only anecdotal. I don't have data to provide you, but we do hear about our WWAMI students in their last years getting offers from facilities to just pay off whatever they would owe the state of Wyoming. And we know it's happening more and more, which is both a testament to the quality of student that we're producing through WWAMI and also the danger of not continuing to fund it. The other concern on the funding side is the University of Wyoming and the state of Wyoming has an agreement with the University of Washington. That tuition payment goes up every year. And it used to be that the state of Wyoming then would meet that, the increased cost from the University of Washington to train our students. The state of Wyoming was paying, and in recent cycles, that's been absorbed by the WWAMI program, and they have been able to pay it with some funds that they have, but we're coming up on a time when they're not going to be able to, and that's going to have to then increase student tuition. And so the deal that WWAMI used to be in 2000, 2001, 2002 isn't quite the same deal for Wyoming students in 2026 that it was at one time, because the state of Wyoming isn't keeping up with how, the University of Washington increases tuition, that increases to us. As that gets passed on to the student, the shininess of WWAMI sometimes can start to sort of wear, and you have this problem with other states trying to pick off our graduates, offering to just simply pay off whatever debt they would have to us. And so those are challenges that we'll have to continue talking about.
Market is competitive. Yes, Representative Clauston.
Thank you, Madam Chair. Thank you, Ms. Bush. Yesterday, we talked a lot about the rural healthcare transformation funds and the tight schedule that they were on and all that. Was your organization involved at all in the discussions?
Madam Chairman, yes. The Medical Society did our own sort of town halls. We got ideas. We submitted all of those to the Department of Health. One that we were the most proud of and I think has the most promise was a complex care coordination hub. Our request was that the Department of Health set up some sort of unit that could support physicians in doing synchronous telehealth visits when their patients need specialty care. And so the idea was brought to us by a pediatrician who cares for a population with a disproportionately high percentage of diabetes. And when she gets to the end of her comfort level taking care of complex multi-diagnosis situations, she has to send those patients out of state to a pediatric endocrinologist. And often the travel is very expensive. It's a community that is fairly deferential, and so their ability to sort of advocate for themselves isn't always all that it could be. The visits are short. The specialists in out of state, they give them a 20-minute visit and they do the things. And she said they frequently come home scared of their diabetic medication because they've been given all the warnings of insulin. And so even though it's a life-saving piece. And so her vision was, it'd be really great if those patients could still just come to her clinic where they're comfortable and they're familiar and they know her and she knows them. This particular physician does a lot of home visits. She knows their living conditions. She knows everything about the family, and have that specialist telehealth in, but with her in the room. Right now, because of a myriad of barriers, both of those physicians in today's landscape can't be paid for that visit. One of them would have to do it for free, and it's certainly not going to be the out-of-state specialist who does that. And so what our idea was in the Rural Health Transformation Fund was some sort of support where either the local physician would still bill insurance or Medicaid or whomever it was like normal for that family to come in and be part of the visit, ask the questions. They would see the specialist, but their family physician or pediatrician would also be there, able to have a very high-level conversation, physician to physician. In the midst of that, the pediatrician is learning more and more because it's like a real-time, the more of those they do, the better and more comfortable they're going to get keeping people. The specialist is probably more comfortable because they both have the chart, they both have everything. And that the state of Wyoming could maybe look at the top 5 conditions or the top 5 specialists that patients are leaving the state to see and do a pilot or some sort of an initial contract and put them on some sort of agreement with the state of Wyoming. We would have to fund it, hopefully with some of the funds from the Rural Health Transformation Fund, to pay them a flat rate to do those visits. So the pediatrician would bill the code for the insurance and get reimbursed normally, and the state of Wyoming would reimburse the specialist for doing those visits and those consults and see how much it actually would save the state of Wyoming. You wouldn't have I think Medicaid pays for some travel, if I'm not mistaken. That wouldn't happen. You wouldn't have the time left from work. I think all in all, synchronous telehealth makes a lot of sense. Right now we have asynchronous. And so, a PCP gets to the point where they say you need a specialist. And then even if they do the telehealth visit, maybe it happens on the patient's personal laptop, or even if it happens in the office, the physician is normally not there. So we feel like it's a really good opportunity for Wyoming to explore keeping our patients here and utilizing specialty care in the surrounding areas that we don't have the volume to support. That was just one of them, but yes, we were involved. That was our favorite idea. And I don't know what will come of it.
Any other? Representative Rodriguez-Williams.
Thank you, Madam Chair. Ms. Bush, was this innovative or modeled off of another state?
Madam Chairman, I think it was innovative. It was just this pediatrician who was really frustrated and said, I just want to keep these people here because they go and they're not asking maybe all the questions I would have asked, or they come back so scared because they don't have a relationship with that specialist. They come home and say, I don't know, they want us to take these other medications, but I didn't ask this. And, it's just, people don't feel taken care of and wrapped around and held tight, and they're scared anyway. And so I think it was innovative. I don't think it was, I didn't find any other states that put it in, not in the way that we were thinking, very specific to synchronous telehealth and like finding a mechanism that we could make that happen. But I didn't exhaust all 50 states, so I don't know.
Any further questions, committee? All right,
Thanks.
thank you very much. How many more people do we have that want to testify on this? A couple few? Okay, let's do this. let's take and I'm going to set my watch. Let's take a 10-minute break and we'll come back and then we'll finish this up. Wrap this topic up and then go on to the next. All right, if everybody would take their seats. And those, I'm sorry. All right. Welcome back. We're gonna finish up with testimony on our topic of just a small little topic of healthcare provider shortage and accessibility of healthcare. So welcome, whoever wants to go first, and thank you for coming.
Thank you, Madam Chair, Greater Committee. Curtis Biggs with Governor Gordon's office, Senior Policy Advisor. Thank you for having me here this morning. I will be brief in part for timing, but also just to speak to the governor's healthcare workforce task force, the work that they did and still can do, add to. I think it really aligns very well to the discussions we've had today. From the CNA and even MA discussions we had this morning, those clarifications that were made. A lot of us relate to that as well as, and it didn't come up as often this morning, but the EMS piece, the task force within, or the workforce within the EMS line of healthcare is also really critical. Those areas were all covered within the task force and wanted to make sure that the data, the analysis, the recommendations that came from that, some of our committee members have seen that in the past. Happy to bring that forward. It's still relevant, arguably still current, aligns well to, again, the topics that came up this morning. We could provide that information, and I asked Jen Davis to join me here as well. She was in the thick of that. She was my predecessor in this position for the task force, but the analytics, the work that was done statewide, I emphasize, meaning the composition of the task force, the subcommittees, brought together certainly the agency, Department of Health was really critical in that work. The agencies, the organizations, the hospitals, that representation in the committee, the task force and the subcommittees, I think was really reflective of what we were hearing this morning and the solutions that you're looking to come up with, the role that the legislature and this committee trying to determine that could really lead to a lot of, I think, solutions as well. The recommendations that were put in front of me by Jen when I started really opened my eyes quickly as I started this position. So wanted to put that out there, and certainly whether it's Jen and there are other folks that were part of the task force and the committees here today. So they may have something to add as well, whether it's today or ongoing. And lastly, the WIP, Governor Gordon's Economic Development Initiative WIP, the healthcare category of that is where I really got attuned prior to this position through my work at the university alongside Jen and everyone else, Lauren Schenfeld. The work on that category, the healthcare category of WIP, there were also findings there, a few studies that were done that I'd be remiss not to bring that up this morning as helpful to this particular health workforce shortage. Thank you.
Thank you. I appreciate it. Committee, any questions? Davis.
Good morning, committee. Chairman Brennan, I'm Jen Davis. I'm with the Wyoming Primary Care Association. I'm here to just give you a quick little brief on a couple of the things. Ms. Bush referred to several of them earlier in her testimony, so I won't spend time on those. But a couple of things that were brought up was around the data. Governor Gordon had done an executive order through the recommendation of the Health Task Force to work with all of the healthcare licensing boards to get better data out of them. So that executive order required them to all come together as licensing entities and determine what questions needed to be asked at licensing renewal to really get a better sense of who was actually working in the state, what their hours of operation were, the specialty they had, if they had one. And so the boards all license on different timeframes. So some of them are already doing that. Some of that might be in their next renewal period. But that is something that your licensing boards would be able to give you some additional information on as they bring those online. The other thing that was really important that they did through the health task force was a behavioral health pipeline. So I know that we've talked a lot about behavioral health yesterday, but there was a really large group of stakeholders that included the payers, the university, the community colleges, providers that really sat down and looked at in Wyoming, we have a great nursing pipeline. Like you can start with CNA, CNA2, MAC, LPN, RN. It's really clear. The pathway for that is really clear in Wyoming, and I think that is really done well. We don't have that same streamlined process for many of the other healthcare professions in Wyoming. And so this group was put together to really focus on the behavioral health pipeline. And that work really started out with entry-level position was where they decided to start and look at whether that be a behavioral health tech, a behavioral health aide. There was no consistency about what people were calling them, what the requirements were, or how individuals seeking entry into those positions even knew what to look for. So that was where they started. They actually came up with a curriculum line of what that would look like. And that's kind of where that work had ended. I believe LCCC is taking the lead on some of that work now. But there is still opportunity to continue that discussion to further build out that particular pipeline. In Wyoming, we have a lot of professions. We have a lot of different licenses in Wyoming. And so really making sure that students come in that can have a clear trajectory of how they want to enter the profession and then maybe work and then upskill throughout it. I think is a great way to look at that, and great opportunity started there. And some of those players are in the room here today. I would think then the last thing that I'd like to share that the recommendation that Ms. Bush talked about earlier, and I think there were some questions on, and this came up yesterday about the recommendations that came out of the OB subcommittee and the regionalization question that is in part of the documents that I'll get forwarded to you all about that Alaska model. We had several conversations with Dr. Hirschfield out of Alaska who helped kind of shape some of that conversation. So that is actually in that document that I'll send to you all that Ms. Bush mentioned earlier today. And then the last thing was the recommendation that came out of the Health Task Force was the establishment of an ongoing healthcare commission or some sort of body for ongoing. There had been some idea of some proposed legislation a couple years ago around that. We have different commissions and bodies around other topics in our state that are complicated. We do not have one on healthcare anymore. We've had several in the past. And that was a recommendation that came out of that group to establish an ongoing stakeholder with legislative representation on it for the long term to keep these conversations going, because healthcare is probably one of the most complex industries out there, and really just having an opportunity that the thought was particularly this committee could lean into for the long term to continue that work from going. So that was another thing that came out of that work group. So those are just kind of some of the highlights. As Mr. Biggs talked about, there's a lot of data. There's a lot of EMS data that we did, lots of recommendations around that. And again, I think you have some of that infrastructure in place to tap into as you guys continue this conversation. So I think that's all I have to add on that, and would take any questions.
Thank you both very much. Committee, any questions? No, I appreciate that information, and since I'm a little bit newer on the committee, I would, if you forward that to those of us that are new, and maybe those of us who aren't can find theirs, but I always love it at the top of my inbox, so appreciate it. All right. Anybody else? that wants to testify on healthcare shortage and accessibility? Welcome.
Thank you, Madam Chair, and committee members, Melinda Carroll with the Wyoming Pharmacy Association. I just wanted to address a couple of the things that had been asked about or talked about. And we too know that scope of practice discussion can be very uncomfortable and maybe even give people the glooms. But I would say that it's work that is going to be necessary because refocusing the picture, what we're talking about is healthcare shortages, provider shortages in Wyoming. And the reality of it is our population is rapidly aging, and the shortage that we're experiencing now of primary care providers is only going to get worse as the population gets older. We already have a shortage of estimates are everywhere from 100 to 350 primary care providers. And we're looking at addressing this now. So we have a lot of ground to make up. And all I'm asking everybody to consider is to use all of the tools in the toolbox that you have so that you can address this shortage in a timely manner so that we don't fall further and further behind the curve. And we are here to try and help with that. And some would ask, well, what do pharmacists get out of this? I can tell you one piece is, yes, diversification of income streams, because as we all know, our small independent pharmacies are suffering. They are having a hard time making ends meet. And if you want to help them in that manner, that's a very great thing to do. The other thing that I would say is career satisfaction. These people are trained to do far more than what they're allowed to do, why they're statutorily allowed to do. If you attend any number of the classes that these students go to, you would see how much training these people get. And when we were having very good discussions about why people leave places, it is because they have a lack of job satisfaction. So are we going to look at shipping more of our students out that are graduating from the in-state PharmD program that we have here at the University of Wyoming and shipping them out to states that allow greater practice, like Idaho and Montana and Colorado and Iowa and New Mexico and California has advanced practice pharmacists. So there are many states that have some form of this, just not standard of care like we are asking for. And so I would highly encourage the committee to consider this as a priority to help address the healthcare provider shortage in the state. I think everybody's concerned with their piece of the pie. I would argue that the pie is so large right now that we would never be able to eat it all. We're dealing with slivers of the pie that are being consumed. So instead of fighting over slivers, let's try and take care of the whole pie. With that, I would stand for questions.
Committee, any questions? Co-chairman.
Thank you, Madam Chairman. Ms. Carroll, okay, you're talking about job satisfaction, and we've heard that from a lot of other people. And honestly, I know it from my own life experience. A lot of things are important, but job satisfaction is the thing that keeps you there or allows you to move on down the line. So right now, are you telling me, because we have different scope of practices for different job descriptions and jobs, period, for different professions, is the main thing that you're speaking of pharmaceutical? And if so, is it all statutorily? Is it by a board requirements? Is it, what is it?
Chair, Well, then Brennan, thank you, Co-Chair Ottman. That is a fantastic question. Really what it is the training that we receive far outstripes the abilities in the practice setting in Wyoming pharmacies right now, community pharmacies specifically. So yes, you can go to a healthcare system like an IHS or a VA, and you can do the things that I have talked about, and they work in a much more collaborative setting where pharmacists often manage those complex disease states, or not the complex, excuse me, the chronic disease states like diabetes and hypertension and high cholesterol and those patients that take up a lot of our healthcare bandwidth. The pharmacists manage those, your anticoagulation. So there, instead of going to a community pharmacy to practice where you can help the immediate people that are coming in without appointments and just coming in to see you anytime, they're not going there. They find jobs at the VA. They find jobs at IHS. They find jobs at hospital systems. They find jobs in other states like Idaho. These border states that have these capabilities, they're looking for those options and those opportunities because you are taught to assess a patient. You are taught to read labs. You are taught what entails a disease state, what lab numbers you're looking at, A1C and cholesterol and electrolyte levels, all of those things we're taught to assess. Kidney values, liver values, those are especially important to a pharmacist. So we know how to do these things and they're not being able to use these skills. And so yes, we will start, and we have already started to bleed. I'm sure that we can speak to this, the number of graduates that graduate from the University of Wyoming and then go to practice in Colorado. It's a very high percentage. So I would encourage you to find ways that we can keep our graduates here and expand the healthcare providers that are in the state and use the healthcare providers more efficiently, more effectively that are already here in your communities, and just allow us to do what we are capable of doing. Those allowances have to come statutorily. The other states have done it statutorily. Generally, it's not as strong if it's by rule and can be challenged or changed by the next person that is in charge of those rules. Thank you.
Thank you, Representative Rodriguez-Williams.
Thank you, Madam Chairman. Ma'am, forgive me for not asking this yesterday, but I'm just curious, what is the relationship like between the association and the program at our land-grant university? And then second, have you got a feel for what, say, the dean or the program itself at the land-grant university thinks about the scope of expansion that's being discussed by this committee?
Chair and Representative Rodriguez-Williams. Yes, I am in close communication with the school, the university, and the association generally host events together, work together, advocate for the profession together, not advocate to you all. I know they're not allowed to do that, but yes, advocate for the profession together. I actually spoke with the dean last night after we had the conversations here, addressing some of the shortcomings it seems like we are having to deal with. One of which being people do not know what pharmacists are trained to do. And that is one of the shortcomings. And that's something that we are looking at how to address that gap in knowledge that we have allowed to grow. So we are looking to do that. But yes, we work very closely with them. And the school is well aware that they need to find a way, an avenue to make Wyoming appealing for Wyoming graduates. Just as WWAMI has to deal with that, pharmacy has to deal with that as well. And so we are looking to pursue every avenue that there is to keep our graduates here, to increase healthcare access in Wyoming, and to honestly, this might be altruistic, but my ultimate goal is to better help the population of Wyoming. We're one of the most unhealthy states. I would like to see that improve, and I think that pharmacists could play a major role in that. And so we're just asking you to take up that task of, yes, it's an uncomfortable, big task, and you do have to be parts of uncomfortable conversations, but I don't think it has to be personal either. And go forward with this and try and replicate some of the models that we have seen work in other places. Thank you.
Further questions, committee? Representative Clouston?
Thank you, ma'am. Thank you for being here again. Just a quick question. Enrollment, graduation rates, University of Wyoming Pharmacy School. Can you give us any idea of are those increasing, decreasing? How do those numbers look?
Well, thankfully, thank you, Chair Brennan, Representative Clouston. Thankfully, they have been increasing in the past 2 years. However, I would say because of the degradation of the pharmacy profession, because it was seen as a largely dispensing role, their enrollment was down. Again, career satisfaction, right? And I would say that the pandemic had a large role to play in that, because while other clinics and hospitals could, shorten their hours or not even open, pharmacies were open. We were there, and it burnt a lot of people out. We were giving vaccines, they were doing testing, we were there. So we saw massive turnover and low enrollment in programs across the country. This isn't exclusive to Wyoming. They are looking at a shortage of approximately 5,000 pharmacists in these coming years, 26, 27. So 5,000 pharmacist positions are going to go unfilled because of the degradation of the profession, largely because the statutes have not allowed us to practice where we're taught to practice. And so we have seen the lack of enrollment. Interest has again picked up, and you're seeing enrollment not at full enrollment. I would say our class is probably at about 45 to 50% enrollment, and the university is able to take 52 students a year. My class that I graduated with in 2013 had 52 students. It was a very competitive program. I was up against a potential of 634 other applicants to that program. And now it's hard to get 20, 25 students in there because of the application rates falling. And that is another part of this, because if you make that career more fulfilling for them to go into, they're going to want to come and go to the university here and graduate from it. It's an amazing program, well spoken of, and very much desired graduates. So let's keep them here, and hopefully we see continued increase in enrollment. That's what it looks like. It looks like it's trending up.
Thank you. Co-chairman.
Yes. Thank you, Madam Co-Chairman. Okay. I don't know where I've been. I know a couple years ago, I'd say a few, 10, there was quite a few people that I knew that were going to pharmacy tech school. They said, I'm going to go to be a pharmacist. I'm going to go. And then a lot of them never, they went, and it wasn't like a 4-year or even 2-year. It was a shorter time period, seemed like. And so I was kind of wondering about that, and if there's different graduated levels. But also, until I had to deal with, my brother had a terminal disease, and so I went to help him. And then I developed a close relationship with the pharmacy for a lot of different reasons. I had no idea, and I still don't, what all a pharmacist can do. You go into a little place, they're busy, so you don't want to bother them with a lot of questions. And then when I was standing in line and there was people in back of me, I just tried to get whatever prescriptions and get out of there. I would like to see what a pharmacy grad student can do when they come out of UW, or what they can do when they come out of one of these farm tech classes or schools or whatever. What actually you can do and what the statute says you can do, because I had no idea. I still am kind of, it's still kind of a gray area with me. So if I had some particulars, I think it would be a lot easier to share that information.
Chairman Brennan, Co-Chair Ottman, thank you for that question. That is probably one of the things that we struggle with the most in pharmacy. There are different levels, as you say. A pharmacist is a pharmacist, though, and there is only one way to become a pharmacist, and that's to go to a doctor of pharmacy program that is accredited. The programs that you are speaking of, that are pharmacy technician programs, those are supportive staff for us. So those would be like a CNA type position or an MA type position, but we actually do have requirements and vetting and training, and they license with the State Board of Pharmacy, but they are pharmacy technicians. They hold their own license, and there are different avenues you can do on the job training, but there's an hour requirement. You have to sit and pass a certification and license with the board. Again, the education requirements are much less for them. However, they are there for a supportive function for pharmacists, so that the pharmacists can really do the job that they were trained to do, which is interact with the patients that come to our counter, give that extensive counseling that they need, go check their blood pressure, check their blood glucose, do a medication therapy management session with them, go through their medicines to see if they are on what they should be, or if they are experiencing side effects from that, or if there's maybe a different treatment that would be better suited for them or more cost effective. There's many things that we do in that right then and there setting. In the hospital setting, we are the ones that are verifying the provider orders to make sure that they are appropriate for labs that we have. If there's contraindications with medications that they're on, especially because they're on medications from home that people don't often think about. There's several areas that we touch in healthcare. There's solid organ transplant pharmacists that specialize in literally just transplants. There's oncology pharmacists, and these are the ones that do the residency. Again, all pharmacists are clinical pharmacists. We all have the same background. It's those that specialize with residency training. So it is extensive training. It is at the minimum of 6 years for a pharmacist, and most are 8 years because they do a bachelor's degree prior going into a professional program that is a 4-year program, 3 years of didactic, 1 year of clinical training that does consist of that 1,740 clinical hours. And so that is the difference between the support staff of a pharmacy technician and the pharmacist. And those are generally the two people you will see in a community pharmacy. You may also see clerks, and those are just exactly what they sound like. It's a clerk. They are not allowed to do insurance billing even. They are allowed to sell a prescription to you is about it. But yes, I mean, we didn't even touch on, being an insurance specialist. That's something I also am. So there are many things that we are taught and we have to know. And, the Doctor of Pharmacy program is a doctorate level program. And it's a doctorate program that the University of Wyoming graduates students from.
Committee, any further questions? Senator Scott.
This, and really I'm facing a dilemma, and maybe the witness can help us out. It seems to me that pharmacy, you have great deal of medical training that we really aren't making effective use of. And you have to understand how the drug is going to be used. So you have to have quite a fair exposure to in training for the clinical, what goes on with the diseases. But you really aren't trained to make a diagnosis, because I would think the training does not necessarily go to all the indications of whether somebody has this disease or that disease. So you know a fair amount about them once they are diagnosed. But I can't see how we can expand the pharmacy training into making a diagnosis without radically changing it. And how do we change the limitations in what you can do now such that we can use the knowledge that you are getting without getting into things that really would require a lot more and a lot different training than you get?
Madam Chair, Senator Scott, thank you for that question. I think that that's also a misconception that happens. The states that have the models where they are standard of care prescriptive authority states, they have not changed their education at all. And it is because when we are taught what we're treating and what receptor that drug is working on and how that goes through the body and what it is affecting, we also have to know the diagnostic criteria to get there. Because we need to know if there was a misdiagnosis for a patient. I go through patients' labs all the time to look and see if I feel the therapy is appropriate that they've been prescribed, because we know the lab values, we know the diagnostic criteria. We have to know that for the guidelines that we are making recommendations based off of. So that is something that we are actually taught in pharmacy school. These are the diagnosis. This is how this disease state is diagnosed. This is what this disease state does to the body. And this is how the drug acts in the body to help improve that disease state. So we have to learn the whole pathway, because if you don't have the whole picture, you don't have a good concept of how that drug is working in the body. So we do have the full picture. We even have a class called patient assessment. You have to be able to assess a patient when they come in. Blood pressure and monitoring of pulse rate and oxygen levels and all of that. We are taught that in school. It is a very extensive program. And I would encourage the committee to invite the university here to talk about their program and what all they have incorporated in it, because the pharmacy education and profession has evolved tremendously, and tremendously in the last 26 years, specifically where it was required to be a doctorate degree. We have added more and more and more and more education in those programs to make it fit with our modern healthcare system and to make it so we are the most useful that we can be in the capacity that we can be. So yes, those other states I think would also be a good resource for you guys to maybe call upon to see if their education levels have changed or if they have seen any issues, because that is another thing. Those states that have those advanced practice or those full scope practice have not seen an uptick in liability suits, liability complaints. There has been overall high satisfaction when you see a pharmacist for, say you're getting treated for a UTI or something of that effect. There is up to a 98% satisfaction rate of those patients. And I know we all are going to be results-based payment at some point. So that's a pretty good result. And I would take a 98% payment on just about anything. So I would encourage you to have those people come and speak or get testimony from them so you have a better idea of what we are trained to do, and maybe talk to some of the clinical faculty of the university that teach the students these skills, because that is exactly what they do day in, day out. Thank you.
Thank you. Committee, any further questions? All right, thank you. All right, we are running a little bit behind. And so in an effort to catch up, if there is anybody here that wants to testify on this, if you would come up, fill all of the chairs. If there's anybody in the room on this topic? Okay, then we will close public comment on this part and go on then to our next topic, which is going to be cancer treatments. And I think we're gonna do it in a slightly different order than is listed on the agenda. Is Bobby online? It would be considered public comment. Is the Wyoming Department of Insurance, are you guys prepared for like?
I believe I am online.
I think that we have like the Department of Insurance and insurance providers kind of to respond to what we have here from Bobby. So I think that's why I'm gonna switch it up if I could. Because she's gonna give us some a couple of ideas and background on some metastatic cancer step therapy and then diagnostic and supplemental breast imaging. Okay.
Can you guys hear me?
We can, yes, thank you.
Oh, okay, wonderful. I believe it's still morning for you guys, so good morning, Chair and members of the committee. I'm Bobby Will, and I'm the Policy and Advocacy Manager with Susan G. Komen. I do reside in Bismarck, North Dakota, and have the privilege to work across the Dakotas, Montana, and Wyoming. And we do focus on improving access, affordability, quality, and ultimately outcomes for people facing cancer. So I do want to thank you for choosing cancer as an interim topic to study. And as you look at healthcare access for patients, cancer patients, we'd encourage consideration of policies that do enhance access under your current coverage structures and curb costs over time. So I'm going to refer to some of the materials that are uploaded. So the first two would be material items 9-3 and 9-5. And one is a fact sheet on diagnostic and supplemental imaging for breast exams. And then I'll reference the metastatic a little later here after we talk about the diagnostic and supplemental imaging. So again, that was fact sheet 9-5, and I believe the policy proposal is the 9-3. So I want to start with some facts about breast cancer so you know why the focus on early detection is so important to families and communities, health systems, and the state. So breast cancer is the #1 diagnosed cancer among women in the US and in Wyoming. It is also the most expensive cancer to treat. And 1 in 8 women will be diagnosed with cancer in their lifetime. So that's when we think of our friends and our family, 1 in 8 is quite a large number. And then the two biggest risk factors are being a woman and getting older. So these are not factors that we can change. So these are the reason that early detection matters so much. Now, most of our state regulated health plans do cover that initial screening mammogram at no cost in the health plan's breast cancer preventative service. But the problem is what happens next. If a medically necessary diagnostic exam or a woman that's high risk, or I'm sorry, if a medically necessary diagnostic exam is needed or a woman at high risk needs a supplemental breast exam, these often are not treated as non-preventative screening, which means the patient will be paying deductible or cost sharing. And that diagnostic follow-up from an initial mammogram is roughly about 12% of women. So for a patient, a callback of that abnormal mammogram is already very stressful. And the last thing they should have to do is pause and wonder, is that continuation of screening considered preventable or not? Can I afford it or not? So what does happen is if a woman 1 year in her initial mammogram was moved on into diagnostic, and then she realized afterwards it wasn't that continuation of her screening, and she does have responsibility on that cost sharing, then a lot of times if that happens in future years, they skip it because they can't afford it or they're afraid of what that cost is. And that's how we do receive higher or more advanced stage cancer. So cost sharing for follow-up diagnostic and supplemental imaging creates a barrier when patients need answers the most. These tests are from a couple $100 to thousands of dollars. But the delays can lead to later stage diagnosis, more intensive treatment, and higher costs overall. And I want to explain a little bit of why there's quite a range in that cost. A diagnostic mammogram will be in that $200 range. But then if you have an ultrasound or a breast MRI, those can start moving into that $1,000 range. So one of our policy solutions would be what is in your material, that reference to 9-3. We do propose that removing cost sharing for medically necessary follow-up for diagnostic exams and supplemental imaging for high-risk patients would be at no cost share. And this does not create a new benefit. These services are already included in the health insurance plan. It simply allows patients to complete the screening process their provider recommends without financial barriers. So as we know, early detection often means simpler treatment, better outcomes, fewer late-stage cancers, lower overall costs, and supports our workforce productivity. When people can complete that follow-up quickly, they miss fewer days of work waiting for answers. They're less likely to face extended time away for more intensive treatment later. So I would definitely appreciate your consideration on that proposal for eliminating that diagnostic and supplemental cost, so it is a continuation of the screening. I would definitely stand for questions unless you want me to talk about the metastatic step therapy first. So Chair, whichever you would prefer.
Let's go ahead. Committee, do you have any questions on this diagnostic and supplemental breast imaging at this time? Okay.
I see no questions at this time, so if you want to go on to the metastatic step therapy, that would be great.
So that would be on your materials, items 9-4, the fact sheet, and 9-2, proposed model language. And in the fact sheet, it does reference some data on breast cancer, but this proposed language is for all cancers, not just breast cancer. So even though Wyoming does have a strong prior authorization standards, the current law does not explicitly prohibit step therapy from metastatic cancer patients. So this means that patients can still be required to try and fail insurer preferred drugs before getting the treatment their oncologist has determined is appropriate. In statute 2655, we would like to suggest adding a narrow exception that prohibits step therapy for patients with advanced metastatic cancer and related conditions. The goal is straightforward. When someone has metastatic cancer, they should be able to start the treatment their physician prescribes without avoidable delays. With metastatic cancer, every day matters. Delays can allow disease progression, limit treatment options, and sometimes cause a patient to miss the window for certain therapies. Oncology care is individualized. The treatment sequencing should be driven by clinical judgment and evidence-based guidelines, not step therapy protocols. This proposed legislation does build on Wyoming's prior authorization framework. It doesn't replace it, and the existing safeguards, timelines, and oversight stay in place. It simply adds a narrow exception for a small group of patients with the most serious and time-sensitive diagnosis. This kind of targeted policy can also reduce administrative burden by limiting avoidable appeals and rework that come from delayed care. Most importantly, it aligns insurance practices with clinical reality. For patients with metastatic cancer, timely access to the right treatment is very critical. And as far as the number of metastatic cancer patients in Wyoming, or actually in any state, it's really hard to determine. So I just wanted to let you know that, because usually cancer registries will just capture the stage of diagnosis, not all patients who are later progress into metastatic disease. So if that was one of the questions you were going to ask, I was going to let you know I don't have an exact number on the number of metastatic cancer patients in Wyoming. So I'm happy to answer questions on the diagnostic imaging or the metastatic cancer now or later.
Thank you. Senator Scott, did you have a question?
Yeah, very quick, Madam Chairman, technical question. 2655 is not a complete statutory site. Wyoming statutes. What, and maybe the staff knows what law they're referring to.
Madam Chairwoman, Senator Scott, that's 2655-101 through, I think it's 105, if I had to guess.
Okay, so
I'm pretty sure that's accurate. What's that?
Part of the insurance code.
Yes, it's part of the insurance code.
Okay.
Thank you. Representative Costin.
Thank you, Madam Chair. Thank you, Ms. Will, for being with us today. I have several questions and then some probably background for the people in the room and on this committee. First of all, are you aware of Wyoming residents, the step therapy that you're describing being skipped? Has this been going on, or is this just more of a national movement that you're looking at?
It does go on. It is very hard to determine exactly which health plans do it, because as you know, there are grandfathered, there's state plans, there's self-insured plans. So I can't list the different plans, but yes, without a doubt, it happens in every state, unless there's legislation in place, but it does happen in Wyoming.
Follow-up.
Follow up.
Thank you for that. So just a little background, when we passed the prior authorization bill in 2024, we involved, everybody that we could on a task force. What we have found is that we've had really good partners in Wyoming with Blue Cross Blue Shield of Wyoming and our Cigna state plan. They follow what the law is. So we have Wyoming citizens getting care in Wyoming from Wyoming licensed providers. But the problem is we have this ERISA law, which is a federal law from 1974. And these out-of-state insurance companies follow that, and they tell us they don't have to comply with Wyoming law. So even if we pass something like this, the two insurance companies will be affected, our state plan with Cigna and Blue Cross Blue Shield. It still won't have any effect on these out-of-state insurance plans. So the committee needs to be aware of that. We don't want to punish our local providers and still not have influence on these outside providers from these other states. So I can tell you as a provider, I run into this weekly with insurance carriers from Texas and Minnesota and California that just tell us they don't have to follow Wyoming law. And I think some of the people on the task force can probably speak to that. So again, just being careful. And then with the screenings for cancer, maybe the Department of Health can speak to this, but I know we do have a plan for cancer screening up to 250% of poverty level. So those funds are available, and maybe someone can speak to exactly how that plan works.
Representative Rodriguez-Williams.
Thank you, Madam Chairman. Through you, Representative, you use the word punishment, and we're talking about timely access to care when it comes to these barriers that cancer patients are experiencing. I'm just curious why you view it as punishment, although we only have 2 insurance carriers that you've mentioned. If you could elaborate.
Madam Chair, thank you. And thank you for the question. So what we've seen is we're making our Wyoming insurance companies comply with laws and have some increased costs, possibly that the out-of-state insurance companies aren't, which if we increase their costs in Wyoming, are we affecting the way they can do business in Wyoming? So maybe punishment isn't the exact word, but increasing costs maybe to our 2 local insurance carriers that are providing these cares in Wyoming.
Senator Scott.
Madam Chair, one technical correction. It's not is the company in state or out of state. It's the ERISA law forbids us from regulating self-insured employment-based coverage. And if they're just an out-of-state insurance company selling product here, we can and do regulate that. But it's the large corporate employers, which are large enough to be self-insured, and they include a few local ones too, that we can't touch. And they've hired some of these people as third-party administrators, but it's an unfortunate way the federal government has done things. And the point is very valid, that there's a major part of the covered market we are forbidden by the federal government from regulating.
Anything else from the committee on this? Okay. Oh, yes, go ahead.
Senator Brennan and the committee, I just wanted to speak to a few of the items that were brought up. As far as the diagnostic and supplemental imaging, we do have legislation at the federal level that has strong support, and we do know that you do have to work at it from a couple different angles. So that would cover then the ERISA plans and like TRICARE, because those are not state regulated. as well as the breast and cervical program. I actually had the privilege of working in that program in North Dakota for 4 years before I came to this position with Susan G. Komen. And those are for un and underinsured individuals, but actually Wyoming is very special because you have the Breast Cancer Initiative Plan, our organization, which also supplements that program. But this is the segment of self-insured plans where if they don't know about it or they don't realize they can apply or money is short, that's why we would want that continuation of screening in that state plan, because that initial mammogram is covered. So if there is another screening that's needed to either rule out that cancer or move someone to a biopsy, we would like that continuation of screening, covered under that preventative initial screening. I think that was everything that was talked about, but I can answer further questions on the breast cancer initiative or the breast cancer plan in Wyoming if you need.
Thank you. Further questions? Okay. Wyoming Department of Insurance, do you have any comments on this? Welcome. Thank you for joining us today.
Thank you, Madam Chair, members of the committee. My name is Tana Howard. I'm the Deputy Insurance Commissioner. With me today is our Senior Health Policy Analyst, Jill Reinking. Just a few comments to what was spoken about. I think the most appropriate probably party to talk about it is going to be the insurance company, because anytime we're talking about changing coverages and things like that, it's going to have an effect on costs. But another concern is, as we're talking about with the market, we did a market study a few years back, 2018, 2019, and yes, largely Wyoming's insurance market is regulated by the feds, right? I mean, whether that's Medicare or Medicaid or the marketplace, Wyoming has a large portion, over 70%, 70 to 80% is regulated federally total. What's regulated at the state is back in 2019, which we're working on recreating this right now with these numbers, was less than 15%, right? That our department specifically in the state regulates. But with that said, also, anytime we're talking about, this type of coverage change, Wyoming is a direct enforcement state. So what that means is with the federal marketplace, when they go to healthcare.gov, Wyoming does not, our state does not regulate those plans. We have over 40,000 people on the exchange. CMS regulates those plans. Other states do have specific laws and regulate the marketplace plans. But because of that, what could happen is this type of change could be thought of as a coverage mandate. And when that happens, the federal government basically says, you have stricter state laws than the feds, right? Than CMS. And so therefore, because you've went beyond the scope of CMS and the essential health benefits, you as the state have to pay for this. And we have done this in the past, years and years ago. There was a law within our code that allowed for, that mandated a specific treatment, and the state had to pay. Our department, right, and the state of Wyoming had to pay that. It was millions of dollars before we could update our essential health benefits and things like that with the feds, which due to the federal changes right now is all kind of up. A lot of states are having problems with this exact issue because they've made changes to their essential health benefits and all of their over the years, over the past 10, 12 years. And now the federal government is making changes to the Affordable Care Act. And they're basically coming back and saying to these states, you're probably going to have to pay for all of the changes that you're having. So there's a lot up in the air right now than there's ever been with this type of issue. But that's just a concern I'd like to bring to the committee to consider when we're talking about this. This is something we'd have to get formal, obviously the decision from CMS, which we're happy to do, and we can talk to them, and we plan on doing that. But I just want to bring that to the attention of the committee. Other than that, I'm happy to answer any questions and things like that. We're happy to maybe take back do some research to see exactly what type of states and what other states have passed this. That would be my question. And I'm just saying that out loud to myself to make a homework for myself. But again, happy to, try to answer any questions for you guys.
Thank you very much for that information. That's very helpful. Committee, any questions? Okay. Thank you. Any insurance providers wish to testify? Welcome. Thank you for being here.
Much, Madam Chairman, members of the committee, thank you very much for the opportunity to come before you and speak on this proposal. What a better place to live than in Wyoming, where we can come and have these conversations. And this is a fantastic opportunity for us to, understand what this may entail and to make sure that we are getting the best treatment that we can and the most effective treatment that we can to our patients. We appreciate those efforts and the continued work. And as this develops into a more specific bill, as the good senator already pointed out, how that goes into statute, we may have more specific, talking points or matters that we'd like to bring to your attention as that moves forward. A couple things on the two proposals that we'd like to bring up for your consideration is simply that, on the step therapy side and that prohibition, it is, at least in the proposed legislation that is included in the materials, not only for cancer treatment directly for the underlying disease, but also for associated conditions. And we would like to promote the most effective treatment for our patients. And just a clarification there is whether or not this would prohibit generics over brand names. That seems to be included in the definition and something that we would like just a consideration on as well. We'd also, as this goes into statute, request that, and encourage this committee to consider reflecting the same standards be included in other state provided coverage, such as Medicaid and other insurance offerings that the state provides as well. This has seemingly a narrow focus on the private market, small group, individual coverage alone. And as the good representative already pointed out, there are exceptions to this that certain types of plans would not be covered by these requirements. So those are 2 points that, especially on both of them, I'd really like to propose. And then just as we consider providing cost sharing reductions, those are manners that we would like to see also getting the best care that we can immediately to folks, especially in the preventative side. We already do comply with those requirements to ensure that preventative services are provided at no cost sharing requirements as well. And as that expands into other areas, just consider how that may affect cost of care overall, because that would just simply be moved then to the underlying premium. And as that becomes, or as that has upward pressure, there's other considerations as well. I would turn it over to my colleague, but first I would like to say, we really appreciate the opportunity to work in partnership. We are here in Wyoming and will work with you on any solution that you feel is necessary. And again, appreciate the opportunity to be here and answer any questions.
Thank you. Yes.
Madam Chairman, could we just ask that you introduce yourself?
Oh, I missed that. Yes, please.
Yeah, sorry about that. My name is Dirk Dykestal. I'm Blue Cross Blue Shield of Wyoming.
Thank you.
Madam Chairman, thank you. Red, Blue Cross Blue Shield of Wyoming.
Thank you for having us here today and inviting us to come up and talk about this. And I'd also like to thank Representative Clouston for mentioning the dynamics in Wyoming with the care that's received and also the coverage that's provided here by local companies such as Blue Cross Blue Shield of Wyoming and the impact that it has on the ecosystem. As a part of the task force this summer, I'm looking forward to that opportunity to talk about affordability. And I also wanted to just mention that I appreciated the comments from the department on defrayal. Being on the federal exchange here in Wyoming, because we don't have a state-based exchange, I think is an important concept to consider when there is a statute that could be considered a mandate for coverage. And I think it's actually really important to point out how that works. So if there is defrayal costs, which is what that means, that it's not a part of our essential health benefit right now to cover some of this imaging without cost share. So the way the federal government looks at it is that the state must pick up that bill. And I think it's important to think about that as we talk about affordability and the cost. We have heard comments or statements made that, you know, the cost of healthcare isn't necessarily correlated to premiums, but I think that it's important to think about that, because if something costs more, the federal government and a state says you're mandated to cover this, the federal government is saying this costs more, and it affects the insurance companies that have to provide that coverage. So therefore, that decision that's being made, the state must pick up that bill. So, you know, in a few years, the insurance company may actually be required to pick that up if the essential health benefit benchmark plan is updated. That needs to happen by the first week of May. And if there's a benchmark plan, you have to tell what that change is 2 years in advance. So a bill like this would need to be defrayed by the state for 3 years, the total cost of it at the very least. So that's something to keep in mind if it is considered a defrayal piece because of the cost of that. But the other thing I would just say is that we support preventative care. Absolutely, 100%. We absolutely support, especially primary care, the kind of care that people get to avoid having catastrophic conditions and having to deal with those for the rest of their lives. So whatever we can do as a health plan in the state of Wyoming to help with that, we're willing to do, but we do have to sort of talk about the cost. And we can do that with an actuarial analysis. We can do that internally and provide you with numbers on what that might look like if we were to implement this in the state. And I think that's an important exercise to go through just to get an idea of what that would be and how that has an impact on other services that we pay for that are not necessarily preventative, that also have a high cost associated with them. Thank you.
Thank you. Committee questions? Yeah, Representative Clouston.
Thank you, Madam Chair. Thank you, gentlemen, for being here. So, you know, this is such an important topic, right? But we want to make sure we handle it appropriately. I think, so would you guys be able to provide the committee with what this would cost the state if we picked up the extra cost? I mean, an estimate, or are you thinking just for your insurance company, or could you give us some idea if we did pass this, what this would look like for the state total cost for the next few years?
Madam Chairman, Representative Clouston, I think that we could do an analysis based on this sort of preliminary bill. I mean, as it gets updated or amendments are proposed, because I know there was already some discussion about potentially amending what we're already talking about. So with the bill draft that we have in front of us, the current one that we see in the materials, we could potentially come up with a projected cost for our population, but it would be much more difficult for us to come up with a projected cost for like the entire state. Although we can talk with our folks internally and see if that's a possibility for us to do something like that. But as I mentioned, likely, especially with the imaging bill, that bill, you know, my read on it is that it would be subject to defrayal. It would be a cost that would be imputed on the state for about 3 years on the federal side of things. So that's a little bit more difficult to, I guess, discuss or determine from our side. And then, you know, we might think of it 3 years down the road and what it would look like then. But to answer your question, we can do our best. And if we aren't able to do it, I'll let you know, but we will get looking into that this week. Absolutely.
Thank you very much. Anybody else? All right, thank you. Okay,
Anybody else wish to testify on cancer treatments? Bobby. Thank you.
Chair and committee. I had the opportunity to work in this legislation in Montana, and so I do have a few answers on the defrayal due to the Essential Health Benefits Plan. And also this has passed in 32 states. But for example, with Montana, the insurance division did reach out to CMS, and because these imaging are already in, it was in Montana's and it also is in Wyoming, these imagings are in your Essential Health Benefits Plan. So there would not be a defrayal. It is a cost share, and I actually do have a letter from CMS that states that cost share is not a defrayal cost to the state. And then Montana did have their state employees actually already covered diagnostic and supplemental imaging at no cost share. So this exact piece of legislation did pass there. And Blue Cross Blue Shield is the administrator for the state plan. They were asked during committee to share about the cost, and they said it was very minimal. And I actually do have that recording of that hearing. Also this year, the state of Kansas said the same thing. They do have, their state employees do not have diagnostic or supplemental imaging, or they have no cost to diagnostic and supplemental imaging with their state employees. And they said it was a cost last year of $234,000 though. But out of the 32 states that have passed this legislation, 20 of them have no fiscal note. But again, I don't have an analysis from the public insurers or the commercial insurers. Those are from the states, that 20 of them had no fiscal note. And I do have that documentation if anyone would like that from me. So I think that's all I have. Thank you.
Thank you. Any further public comment? Well, with yes, we do. Welcome back, gentlemen.
Hi, Dirk Dykstal, Cross Blue Shield of Wyoming. Although we would love the opportunity to serve the people of Wyoming, we do not currently have the state plan here. So I would not take what is happening in Montana as necessarily the gospel truth here in Wyoming. As we are in Wyoming, and the model legislation, still has a lot to be worked through. I'm sure this committee would like to have its own, opinion and maybe even authorship on this. We do need to consider how this affects Wyoming. And I would just strongly encourage this committee to, analyze this from a Wyoming point of view, because the good speakers mentioned something to the effect of no fiscal notes. Well, that doesn't have fiscal notes when there isn't a state agency being implicated in its budget. So that analysis does not necessarily impact what the true cost of something like this would be. When you, a fiscal note is really geared towards what is the cost difference on the state budget. So I think those are important clarifications. And then I would also turn it over to my colleague for anything he would like to add.
Madam Chairman, and I'd like to thank Dirk for providing that information. I wouldn't disagree that purely cost share, meaning preventative waiving of cost share, is something that would result in a defrayal. But I think we have to look at the bills and the differences of those bills that were passed in those states, because what this bill does is it also includes supplemental imaging, dense breast screening, molecular breast imaging, MRI, ultrasound, and diagnostic image beyond ordinary preventative screening. And because it includes those things, we aren't just talking about waiving of cost share. We're talking about additional benefits. And not every benchmark plan in each state is the same. So we can't really compare apples to oranges in other states. We'd have to look specifically at our benchmark plan, compare it to what the bill will do, and any amendments that come through to determine whether or not defrayal would be potential. And just to be clear on my comment, I would agree that just simply waiving cost share wouldn't be a defrayal trigger, but adding other benefits would be, and that is a very tricky subject to have to discuss and talk about. And with the current language in the bill, I still believe that there would be a strong position that defrail would come into play. And if we need to stay up here for additional, we don't want to keep coming back up here, but I just wanted to also make it clear that we do not administer the state plan. And one other comment that was made about federal law, I think that's important too. There was testimony given that the federal law is already covering some of this stuff, so maybe we don't need to worry about the ERISA side of things. But that actually sort of answers the question a little bit too, right? Because if there is federal laws that are covering some of these issues, they're also going to cover individual and they're also going to cover small group. So then we run into the idea of serving two masters, which is also very difficult to do, right? Because then you have federal laws that you have to adhere to, and then different state laws that you have to adhere to. And then it becomes very difficult to navigate through that when the problem is trying to be solved at the federal level already. So thank you.
Thank you.
Madam Chairman, last point that I would like to offer is just, by no means are we speaking against the merits of this bill. I think that it's important that all Wyoming patients have quick access to effective treatment. We simply would like you to be fully informed before you make a decision on what should be mandated coverage and what shouldn't be mandated coverage. And with that, I think we would stand for any questions.
No, I thank you, gentlemen. I appreciate I think we want all affected parties at the table. So committee, any further questions or comments? Okay. Thank you very much. I appreciate it. I appreciate everybody coming and showing the legislation, how it affects things. And so I appreciate all of that. I think with that, I think we have one more online, and I think Representative Rodriguez-Williams has.
Thank you, Madam Chairman. Just a comment. On the topic, we've heard a lot of medical jargon, the costs, a lot of comments about the costs incurred, and I couldn't help but hear the one comment about the interest of a Wyoming point of view on this topic. And I think the one thing that's missing is the patients themselves. It was brought up by the lady that participated through Zoom that 1 in 8 women in the state of Wyoming are going to experience breast cancer. So 1 woman, possibly 2 in this room will experience breast cancer during their lifetime. We have yet to hear from a breast cancer patient or a cancer patient or a survivor come up to the podium and talk about the barriers that exist in this room. The prevalence in this state is real. I want to hear about the barriers that exist. If we're going to have a full conversation about the bills that are proposed, the model legislation. Thank you.
Thank you, Representative. Appreciate that. Looks like we have Denver online.
Yes. Good morning, Madam Chair, members of the committee. Thank you for the opportunity to provide testimony on this issue on agenda item 903. My name is Denver Henderson, and I have the honor and privilege of representing the American Cancer Society Cancer Action Network, otherwise known as ACS-CAN. ACS-CAN is a nonprofit, nonpartisan affiliate of the American Cancer Society, advocating for evidence-based policies that reduce the cancer burden for everyone. On behalf of our constituents, many of whom have been personally affected by cancer, we urge you to support this proposed bill. Most individuals now have access to screening mammography, thanks to inclusion as a free preventive service under the federal healthcare law. However, if the results of that screening mammogram suggest the need for a follow-up imaging test to determine if the person has breast cancer, then individuals may be faced with hundreds to thousands of dollars in out-of-pocket cost, all before treatment actually begins. One study found that these out-of-pocket costs can average about $234 for a diagnostic mammogram and over $1,000 for breast MRI. Now, for middle class folks, that may not seem like a tremendous barrier, but for working class families, that could be significant. And as a result, several states have enacted legislation, as we've heard, to eliminate cost sharing altogether for these follow-up imagings that are needed for an abnormal mammogram. In Wyoming, there's an estimated 500 women that will be diagnosed with breast cancer this year, and 80 people will die from the disease. Despite the fact that breast cancer rates have been declining for several years, not all people have benefited equally from advances in prevention, early detection, and treatments. Evidence indicates that cost is a significant barrier to healthcare generally and to cancer screening specifically, and that the elimination of cost sharing is associated with increased cancer screenings. Cost is also a barrier to completion of follow-up tests that are recommended after an abnormal cancer screening. Unexpected and unaffordable cost may cause individuals to delay or to forego additional tests to rule out or confirm breast cancer diagnosis. And delayed follow-up is associated with later stage disease at diagnosis. The implementation of no-cost preventative services under the federal law has paved the way for more people to get regular age-appropriate screenings. However, cost barriers to completing the continuum of screenings are undermining the desired outcome of determining whether or not a patient has cancer. Without diagnostic resolution following an abnormal screening, the promise of a cancer screening cannot be realized. Given the evidence that patient cost sharing, whatever the source, diminishes the timely uptake of essential cancer care associated with the full continuum of screening, ACS CAN supports legislation to eliminate cost sharing for recommended screening and follow-up testing through the diagnosis of cancer. We thank you for your time and consideration and urge your support for this proposal. Thank you, Madam Chair.
Thank you. Committee, any questions? Senator Scott. And then,
Well, I don't think I did. What would be the cost if we said we just were going to do it for all these, you were saying 500 women that might need it? Just have the state general fund pay for it, bother the technicalities of insurance. What would be the cost to us?
is he still online?
I am. Thank you, Madam Chair. Sorry. Just for clarification, it is 500 women that will be diagnosed with breast cancer this year. That doesn't mean that all 500 will need additional screening. It's just 500 that will be diagnosed, and 80 people this year will die in Wyoming from breast cancer.
Madam Chairman,
Senator Scott.
what would those screenings cost? And do you have any estimate how many would need them?
Madam Chair, Senator Scott, I do not have that information, but this is an issue that has been studied widely, and I would be absolutely happy to do the research and follow up with the chair and with the senator with that information.
Madam Chairman?
Yes, Senator Scott.
I think that would be very useful if we had that at the next meeting, because then we could say, should we just not fool around with the insurance and just make that a benefit? Is that a cost that's prohibitive? I suspicion it might not, that it might well be the best way to handle this one.
Right. Thank you, Senator Scott. If we could get that information, that'd be great. Representative Clauston.
Thank you, Madam Chair. Thank you for your testimony, sir. So just a question with some of these other states that have followed this model legislation. My wife is a breast cancer survivor, and here we are 4 years later, and she's still getting screens. I'm just curious with this other model legislation in other states, how long are these screens covered or not covered? How have they handled these ongoing tests and screens years later?
Are you still with us?
I'm sorry, Madam Chair, Representative. But again, I do not have the specific information that you're requesting. I would be more than happy to work with the folks in my organization to try and find those numbers.
That'd be very helpful. If we could have follow up on that, that'd be great.
Happy to do my part. Thank you.
Thank you. Committee, any further questions? All right, anybody else for public comment? Anyone? Okay, with that, we will recess for lunch until 1:30. So be back here for 1:30 to talk about workers' compensation and public safety communication workers.